Good morning.
Good morning, ma'am.
Hi.
Good morning. Am I audible?
Yes, ma'am.
Sure.
Yes.
Yeah. Okay. Dr. Manju,
Yeah. Hey.
switch on your
Can
video,
you?
please.
Oh, okay, sure. So can you see me?
Yeah. Sure.
Okay. Yes. Can you let me share the slides?
Please, they'll be doing the
Okay.
MNMT, please. Vivek.
Yes, ma'am. We are doing that.
Yeah,
Just a
please give her the privileges to share.
We did that.
Okay. It still says I cannot share.
It's please give the privileges to Manju Pillai. There are two Manjus today. Myself and the speaker both
Ma'am,
share the
please try
same name.
now.
Okay.
Please try now.
Yeah, I can do that. Okay. Okay. Can you see it?
Yeah.
Okay.
Yeah, now it's okay, in the presentation mode only. Yeah.
Okay. Mhm.
We will start by now it's only 8:38. We'll start by 9 o'clock. Let everyone join.
Manju ma'am, did you test your PPT?
Oh, can you see it?
Yes, ma'am, it is visible.
Okay. Were you asking me? Both are Manjus.
Manju Pillai, ma'am, are you testing your presentation or is it done? Because we have to put a kind of a backdrop for the front end. So,
Yeah. Uh-huh.
yeah.
I have shared my presentation.
So you can stop it sharing for now because we have to share some
Oh,
content.
okay, okay. Oh, sure, sure, sure. So I can stop sharing now. Okay, that's good.
Yeah, ma'am. It's good.
Good morning, Dr. Madan. Dr. Madan Raj, good morning. Dr. Madan Raj, am I audible? Dr. Madan? Hello. Good morning,
Ma'am,
Dr. Madan.
morning.
Yeah,
Yeah,
yeah. Now it's audible. No.
Can you hear me?
Yeah.
அங்க கேக்குது.
Yes.
But I cannot see me. நான் தெரியல.
Yeah. Correct.
Good morning, respected faculty, esteemed delegates, and dear students. On behalf of the organizing committee, I extend a warm welcome to you all on the day 2 of 6th International Conference BMS Econ 2026, organized by the Departments of Anatomy, Physiology, Biochemistry, Arabade Veedu Medical College under Vinayaka Mission Research Foundation, deemed to be university. After an inspiring and successful inaugural day, we are excited to continue full scientific deliberations, knowledge exchange, and intellectual engagement. Let us begin today's proceedings with our first session. We begin with biochemistry session, and today's talk is titled Targeted Therapies and Precision Pathways in Pulmonary Disease. To conduct the session, I now request our respected moderator, Dr. Manju Ma'am, Organizing Chairperson, HOD and Professor, Department of Biochemistry, Arabade Veedu Medical College, to kindly take over the proceedings. Over to you, ma'am.
Thank you, Dr. Kalaivani. Good morning to all present in this forum, listening to this, who are all taking part in this talk. It's my, I don't know how to tell, it's my pleasure or pride, I don't know. I have two people on the screen who are actually great friends of mine. The person who is sharing is Dr. Madan Raj, who is a very close friend of mine, and he's the HOD of pulmonary medicine from our own institute. And the person who is going to give the talk is 25 to 30 years best friend of mine, my roommate in MBBS. So I don't know how to, but so it's from morning I was thinking it's a pleasure to have to actually moderate the session itself. So let me get into my work. So first, the topic already is already been told. So let me take the privilege and pleasure to introduce first our chairperson, M&M team. So the chairperson for this session is Dr. S. Madan Raj. He is MBBS, MD, DNB, and FCCP. He's a professor and head of the Department of Respiratory Medicine in Arabade Veedu Medical College and Hospital, Pondicherry. And coming to his academics and experience, he has completed his undergraduation and post-graduation in respiratory medicine from JIPMA, following which he has worked in JIPMA, then Manakala Vinayagar Medical College, Pondicherry, and at present he's offering his services in our own institute, Avmc. He has more than 10 years of teaching and teaching experience as well as research experience, and he's a wonderful pulmonologist with expertise in COPD, lung infections, pulmonary diagnostics, and more than that, he is very well-known, passionate teacher among the postgraduate students too. Coming to his research and publications, there are many, but the recent ones include those related to serum tumor necrosis factor alpha and COPD severity, bronchial wash in lung cancer diagnosis, MRSA screening in miliary tuberculosis, and his studies on hypertension and community health, and the role of magnesium in chronic obstructive pulmonary diseases too. And he is involved into many clinical trials, out of which adds to his research experience. At present, he is having in his hand 3 clinical trials in which he is the main investigator too. So with this is not actually the total resume of Dr. Madan Raj, but still, I would like to give this a small summary with which I would request Dr. Madan Raj to take over the session and please introduce our speaker. Thank you.
Thank you, ma'am, for both the invite and the kind words. Good morning, everybody. Coming to today's topic about targeted therapy in pulmonary diseases. I think it is now we need to know more about targeted therapy because because it's more for the students. I will say for the students it was good to know 2-mark question. Now from that it has evolved to a must to know essay. So with this, you can know the importance of how much we have evolved from targeted therapy. Being it from lung cancer, just treating about EGFRs, KRAS, and ALKs, now it has gone beyond that. Not only lung cancer, even it has gone beyond into other inflammatory disease of the lung, RV diseases, also even into some infections. So to talk more about it, we have a better person, Dr. Manju Pillai. I think her CV runs into pages. It will take at least 5 to 10 minutes. So for want of time, I'm going to cut short it into a 30 seconds thing. So this is not even a gist of what she has achieved. So let's just go through her CV. Ma'am completed her MBBS in Alapi, Kerala, and then she did her MD from New York, and she did her residency in internal medicine from university in Cleveland University. After that, she did her pulmonary critical fellowship from Mount Sinai in New York again. She did her sleep medicine fellowship there, and then following which she had hold multiple posts. Now she is an associate program director in pulmonary critical care sleep medicine fellowship program in New York. Apart from that, she has multiple publications. Some of the important one are the role of alpha antitrypsin in lung inflammations, mechanical ventilations, and the outcomes in cancer patients. OAC and ILD because she has a separate sleep fellowships, and she is also a co-principal investigator in FAMRI funded study on lung inflammation. And she has also authored or co-chapters in multiple books, and the publication lists are much bigger. And so this is what you're seeing as a small part of what
Next
has
slide.
been published. So with this, I'll hand over the mic to Dr. Manju Pillai. Ma'am, over to you. Thank you.
Thank you, Dr. Madan Raj, for your kind introduction. It's an honor to be here, and I would like to express my appreciation for the invitation to this excellent conference. The breadth of topics on the agenda is remarkable and truly impressive. Dr. Manju is my best friend from medical school, and seeing now fully chasing her passion makes me so proud. So I'm presenting from New York, and the time here is 11:30 p.m. All these years after med school, she wants to test that my brain still functions at 11:30 p.m. I have no disclosures. I'm the co-editor for Alzheimer for hypoventilation and neuromuscular disease, and has nothing to do with this presentation today. Objectives of my presentation will be to understand the pathophysiology of asthma and to discuss the mechanism of action of biological agents in the treatment of asthma, with focus on the role of biomarkers and selecting the most appropriate treatment. We will also briefly discuss about DPP1 inhibitor approved for the treatment of bronchiectasis, brensocatib, and also nerandomilast, which is a phosphodiesterase 4B inhibitor that was approved for idiopathic pulmonary fibrosis later last year in the US. So coming to what are biologics? Biologics are complex, high-precision medicine derived from living organisms, often from cells, proteins, genes, rather than chemical synthesis designed to target specific components of diseases. They have revolutionized the care of several diseases, as Dr. Madan Raj has mentioned in his introduction. I will not be able to go through all the diseases, but I will focus on 3 diseases today. Antibodies that target, these are antibodies that target and block specific inflammatory pathways. They can slow or halt the disease progression, and it is very safe and efficient, leading to disease remission. Nomenclature is based on the type of monoclonal antibody it is derived from. Small molecules and biologics have quite distinct physiochemical and pharmacokinetic features from one another. Coming to asthma, as per the Global Initiative for Asthma, GINA guidelines, the definition is asthma is a heterogeneous disease usually characterized by chronic airway inflammation with variable respiratory symptoms such as wheezing, chest tightness, shortness of breath, and cough, with variable expiratory airflow limitations. As shown in this diagram, what you see is airway inflammation, thickened airway, lot of mucus, and narrowing of the airway in asthma. We think of asthma as phenotypes and endotypes. Asthma syndrome is characterized by airflow obstruction and bronchial hyperresponsiveness, which is determined by a spirometry. Spirometer is not a biomarker. When we talk about phenotypes, some patients tell us they have asthma when they visit their friend's house with cat, or after exercise, or after a viral infection. So that is the phenotype of asthma caused by allergens, exercise, or infections. Endotypes, they tie a pathophysiological mechanism to phenotypes. This is where we use the phenotype biomarkers, IgE, pheno, fractional exhaled nitric oxide, and eosinophils. This will help us select the biological agents in asthma. So here we can talk about the endotypes and phenotypes. Endotypes, it can be T2 type asthma or non-T2 type asthma. Today we'll focus more on the T2 type asthma, which includes the allergic and the eosinophilic asthma. And the non-T2 asthma is neutrophilic or paucigranulosity, or related to obesity, smoking-related asthma. So coming to the pathophysiology of asthma, which is Th2 high versus Th2 low pathways. So if you look here, let's go from left to right, just like the image. So the airway epithelium get exposed to allergens, viruses, bacteria, cigarettes, pollutants, or as a result of physical injury, it activates the TSLP, which is the what is called? It's called the thymic stromal lymphopoietin, which activates the dendritic cells, which in turn activates the naive cells, which activates the Th2 to produce the three main interleukins that we focus on asthma, which is interleukin 4, 5, and 13. So interleukin 5 recruits eosinophils. Interleukin 4 and 13 causes mast cells and basophil degranulation. So this is the allergic or the eosinophilic or the Th2 high pathway, which is very responsive to steroids. They are rich in eosinophils and IgE. Coming to the Th2 low pathway, where the TSLP activate the dendritic cells to activate the naive T cells to Th17, and the interleukin 17 causes the recruitment of the neutrophils. So this is mainly neutrophilic inflammation and is a very difficult to treat asthma. Coming to the T2 type asthma again, we have, this slides illustrate the pathophysiology of T2 asthma. Allergens entered the airway lumen and they are taken up by antigen-presenting cells that activate the Th2 cells. The Th2 cells then releases the cytokines such as interleukin 4 that causes B cells to switch to IgE production. Interleukin 13 leads to airway eosinophilia, mucus gland enlargement, airway remodeling, and fibrosis, and increase the pheno, which I will talk later in biomarkers. Interleukin 5 that recruits eosinophils into the cells. So the net effect on the airways is increased mucus production, smooth muscle contraction, airway narrowing, and airway remodeling. T2 low asthma, I'm sorry, I skipped a slide. So there can be high T2 or low T2 pathways. The T2 high pathway is the allergic or the eosinophilic asthma. And the two main Non-T2 or the T2 low asthma is the neutrophilic or the paucigranulocytic asthma. The T2 low asthma, which is the neutrophilic predominant asthma, has been associated with oxidative stress, chronic infection, smoking, obesity, and high-fat diet. They usually have poor response to corticosteroids. And in adults with refractory asthma, that is the neutrophilic airway inflammation, is correlated with increased prevalence of fixed airway obstruction. Paucigranulocytic phenotype is defined by lack of eosinophils or neutrophils and is poorly understood. Given that this may be a potentially corticosteroid insensitive phenotype, then we look into other treatment options such as the bronchial thermoplasty, which is considered in these types of asthma. So this slide summarizes the key immune cells and cytokines involved in asthma, especially the Th2 pathway. Eosinophils are related to the disease severity, and they release the leukotrienes and PAF that causes smooth muscle contraction. Eosinophils are recruited by interleukin-5. So if we have a biological agent against interleukin-5, it will decrease the eosinophils in the cells. Mast cells produce bronchoconstricting mediators, and basophils, they produce interleukin 4 and 13. The Th2 lymphocytes produce all these kinds of interleukins. And as I said before, the 5 interleukins we focus on in the management of asthma biological agent is interleukin 4, 5, and 13. Interleukin 13 causes airway eosinophilia, mucus gland hyperplasia, airway fibrosis, remodeling, and increases the FeNO. So since we know the pathophysiology of asthma, what happens in Th2 high and Th2 low asthma, is very easy to look into the biomarkers in severe asthma. So the common biomarkers that we look into are total serum IgE, absolute blood eosinophil count. Then we look into the eosinophils or inflammatory cells in the sputum or BAL, and also the FeNO, which is the fractional exhaled nitric oxide. Emerging biomarkers are the periostin, serum eosinophil-derived neurotoxin, thymus and activation regulated cytokines and neutrophils. We haven't used these biomarkers here yet, maybe as a part of researchers, but the common biomarkers we use in severe asthma to guide our treatment for biological agent are these 4 here. Talking about fractional exhaled nitric oxide, that is FeNO, which is done in our office during patient visit to guide the treatment. Nitric oxide is an important regulator of immune response and is a product of inflammation in the airway that is overproduced in asthma. High levels of FeNO has been associated with decline in lung function, and an increased level of exhaled nitric oxide in asthma, especially originating in the lower airways, is often associated with airway eosinophilic inflammation. In patients with cystic fibrosis, smokers, alcohol consumption, where the epithelium is involved, because nitric oxide is produced from the epithelium, we can have false negative results. We usually ask patients not to eat hot dog prior to FeNO testing because it's rich in nitrate, which can give a false positive result. FeNO is a parallel marker of inflammation, is often but not always associated with eosinophilia. It should not be considered as a surrogate marker for sputum eosinophils. FeNO is elevated in non-asthmatic conditions too, like eosinophilic bronchitis, atopy, eczema, and allergic rhinitis. FeNO more than 50 has been associated with good short-term response to inhaled steroids. There are different guidelines looking into the values of FeNO, and what or we follow is the ATS or the ERS guidelines. If FeNO is above 50, then it shows eosinophilic inflammation, but not always, and the patients can be very responsive to steroids. Less than 25, they are less responsive to steroids. So if you have a patient with high doses of inhaled corticosteroids or daily oral corticosteroids or with frequent exacerbation, possibility of refractory type 2 inflammation should be considered. And we look for these biomarkers like blood eosinophils more than 150, FeNO more than 20, sputum eosinophils more than 2%, or if asthma is clinically allergy driven. So we always should keep in mind that these biomarkers can be suppressed by oral corticosteroids, and most of these patients will be having recurrent exacerbation and on steroids, and biomarker testing can be altered. Since we know the pathophysiology and the biomarkers in asthma, now let's talk about the biologics in asthma. So there are new biological agents coming out every day. So it's hard to cover everything in today's presentation, but the common ones that we use currently are these. The first one, so if you know this pathway, this is what I explained before, that allergens activate the dendritic cells to produce Th2, which in turn produces the three interleukins, interleukin 4, 5, and 13. Interleukin 5 activates the eosinophils or degranulation to produce eosinophils, and the interleukin 4 causes B cell and mast cell degranulation to produce the IgE. Then there can be, different pathways that is involved and biological agent for TSLP. So the first biological agent that we have is the anti-IgE, that is the omalizumab. That works against the IgE level. It has to be given in the clinical setting, and patient has to come in for the visit to get omalizumab. But this was the commonly used biological agent initially. But now we have many other agents which can be easily given at home. So as I mentioned, interleukin 5 causes eosinophilic recruitment. So anything that acts against interleukin 5 will decrease the eosinophil level. For example, the anti-interleukin 5, which is the mepolizumab, or it can be the interleukin 5 receptor, anti-interleukin 5 receptor, benralizumab. So this works against the eosinophils. So if the absolute eosinophil count is high, this is something that can be considered. Then we have the interleukin 4, anti-interleukin 4, that is the dupilumab. TSLP, the thymic stromal lymphopoietin, is a driver in both allergic and eosinophilic pathway, and also in the Th2, the neutrophilic and polygranulocytic pathway. So it can go in either direction, leading to structural changes to the airway. And the anti-TSLP is the tezepelumab. So bringing the biological, knowing the pathophysiology, the biomarkers, and the mechanism of action of the biological agent, where does it fit into the treatment guidelines, the GINA guidelines? This is the step up and the step down treatment of asthma. We start with one inhaler, the short-acting beta agonist or the combination inhalers. And based on their symptoms, we step up the treatment. And if they are refractory to these treatment, or if their biomarkers are positive, then we use the biological agents for the management of for these patients. So if we have a difficult to treat asthma, so we confirm the diagnosis first. We check their inhaler techniques, how well they use their inhaler, which is not an easy thing to use. Whether we can improve their adherence to treatment and avoid the triggers, at home, work environment that actually triggers the asthma, and look into other coexisting conditions. And if they are maxed out on the treatment, then we look for the serum biomarkers, absolute eosinophil count, FeNO, and then decide which way to go. Currently, we look for biomarkers early in the presentation too. So based on the blood eosinophils, FeNO, and whether it's an allergic component or a non-allergic component, we decide which interleukin, anti-interleukin biological agent to use in the management of these patients. So this is a rough diagram showing like we look into the absolute blood eosinophil count and also the FeNO. If the eosinophil count is high, interleukin 5 or 5 receptor, anti-interleukin 5 or the 5 receptor can be used. If FeNO is high, then we can use anti-interleukin 4 or 13. So these are the 3 interleukins that we use, anti-interleukins that we use in addition to the IgE, anti-IgE omalizumab. So this is the complete graph that I showed before. We had a tough winter. Now it's a cherry blossom time in New York and spring. So now let's switch gear and talk about bronchiectasis, especially the DPP1 inhibitor, brensocatib, that was approved last year, and we started to use this in our patients now. So what is bronchiectasis? Bronchiectasis is the 3rd most common airway disease after asthma and COPD, and it remains underdiagnosed and untreated. It's a chronic inflammatory disease leading to permanent airway damage, increased mucus production, recurrent infections, and usually patients present with cough, sputum production, dyspnea, and recurrent respiratory infection, a very challenging disease to treat. And when we talk about bronchiectasis, we cannot skip the vicious vortex, which includes the airway inflammation, structural damage, infection, and inflammatory response. This is the pathophysiology of bronchiectasis. It can be airway inflammation, dysfunction that leads to airway inflammation, structural damage, or infection, or it can be infection that leads to inflammation or airway dysfunction. In whichever direction it goes, once it starts, each part feeds into the next, pulling the lungs into a downward spiral of worsening disease. Coming to the treatment of bronchiectasis, what we have so far is a very challenging treatment. It's very difficult for the patients to adhere to these treatments as well. The main treatment is pulmonary hygiene, where I tell my patients I'm a plumber. It's mainly to clean your airways. It can be different kinds of inhalers, bronchodilators, mucolytics, and techniques, airway clearance techniques like PEP devices, West therapy, to clean the airway, to prevent recurrent infections. If they have recurrent infections, we use inhaled antibiotics, especially for Pseudomonas, or we consider pulmonary rehab, if they are short of breath and have severe symptoms. Macrolide has been used as an immunomodulatory agent in bronchiectasis. If it is localized bronchiectasis and severe symptoms, then you can consider surgery. And in advanced cases, we refer these patients for transplant. So that brings us to brensocatib, which is a DPP1 inhibitor. Okay? So our goal is to decrease the inflammation in the airway. So DPP1 inhibitor. So as a result of inflammatory response, neutrophils come into the lung tissue and they produce the neutrophil-derived serum proteases, that is the NSPs. And this is activated by DPP1. So DPP1 inhibitor inactivates DPP1. So the neutrophil-derived serine proteases does not lead to destruction of the airway, reduces inflammation, it causes a protease inhibitor balance, and fewer or milder and decrease the incidence of lung infections. So it's a medication that decreases the infection and decreases the incidence of infection. Decreases inflammation and decreases the incidence of infection in bronchiectasis. So that brings us to the Aspen trial that was published last year, looking into brensocatib in bronchiectasis. Bronchiectasis exacerbations was reduced in patients using these medications. We did start to use these medications here, less side effects and better tolerated. Hopefully, in the next few years, we'll see how our patients tolerate this medication. This is the time tulips come out in US as well. So now let's talk about idiopathic pulmonary fibrosis and nerandomilast. This was approved later last year, and we started to use this medication early this year. So idiopathic pulmonary fibrosis, if you ask Dr. Madan Raj, is a very complicated and very difficult to treat disease. Life expectancy is quite low once the diagnosis is made. What happens is that as a result of injury, the repair happens in the wrong direction, leading to increased fibroblast activity, leading to, as you see in the CT scan here, fibrotic tissue with honeycombing bronchiectasis and bronchiectasis, leading to decreased diffusion of oxygen. Most of these patients have progressive dyspnea on exertion and chronic dry cough. We usually treat these patients now with antifibrotic drugs, that is the nintedanib and pirfenidone, which can slow the decline in lung function, but it does not halt the progression. It comes with very serious GI side effects, and most of the patients cannot tolerate these medications because of the GI side effect. So what is nerandomilast? Nerandomilast is a phosphodiesterase 4B inhibitor. So if you look into the phosphodiesterase 4B, is rich in the lung. And there's another phosphodiesterase 4 inhibitor that is used in COPD, that is the roflumilast, which is phosphodiesterase 4D. And this is also present in the GI tract. So these patients have a lot of GI side effects. So we were hoping that this medication has less GI side effects when compared to roflumilast that we used in COPD. So how does this medication works? Increased cyclic AMP in the tissue leads to activation of the protein kinase A. And what the protein kinase A does is it suppresses the inflammatory signaling, promotes the anti-inflammatory gene expressions. So inhibiting the phosphodiesterase enzyme that converts cyclic AMP to 5-AMP, cyclic AMP level goes up, leading to favorable outcome in inflammation, that's decreasing the inflammation. Phosphodiesterase E4 inhibition, it affects multiple immune and structural cells. It acts on the macrophage to decrease the TNF production. It also acts on the B cells to decrease the IgE production. It can also affect the Th1, Th2, Th17 to decrease interleukin production. So what happens with nerandomylast is that it affects the inflammatory pathways. It can decrease the inflammatory response, and it also can affect the fibrotic pathway, where the fibroblast proliferation is decreased. So it has both inflammatory pathways and progressive fibrotic pathways affected, which appears to be promising for the treatment of IPF. So that brings us to the Fibroneer IPF trial that was published last year. It's a double-blinded placebo-controlled trial in 36 countries in patients above 40 years of age with IPF, where FVC is at least 45% of predicted value and DLCO is at least 25% predicted value. And patients can be on or not on antifibrotic agent, but if they are on antifibrotic, they have to be on a stable dose. And it has been shown to decrease the decline in lung function. And this is a 3-month trial. Hopefully, patients can tolerate it better than the other medications that we have for IPF, like nintedanib and pirfenidone, which comes with a lot of GI side effects. So in summary, I spoke about the pathophysiology of asthma to guide the treatment along with biomarkers to guide the selection of the biological agent, and also the mechanism of new drugs approved for bronchiectasis, that is the brensocatib, which is a DPP1 inhibitor, and also mechanism of action of the new drug approved for IPF, that is the nerandomylast, which is a phosphodiesterase 4B inhibitor. And some of the biological agents that we used in asthma has been, as the Dr. Madan Raj might know is better too, has been used in COPD as well. And then touch COPD because there are so many biological agents being worked on as clinical trials. And hopefully in the next couple of years, we will have many agents coming out for COPD. Lung cancer, immunotherapy, checkpoint inhibitors, it's a talk, but it's also, it's a broad topic as well. Thank you for inviting me for this conference, and thank you for your attention. And take questions if you have any.
Dr. Madan Raj.
Thank you, ma'am. Thank you, Dr. Anju. I think it was a wonderful lecture, and to be honest, it was more crisp, but it was also detailed and clear. So though we discussed only 3 topics in asthma, bronchiectasis, and IPF, I think the students will be able to understand the pathophysiology as well as the pharmacology of the entire pathway and why the drugs are used at various levels. I think it was a very nice presentation.
Thank you.
I'll check for any questions in the chat box. Before that, I have a simple question. What is your personal experience with benralizumab? Because here, the moment, if every year a new therapy comes and becomes a savior. Once omalizumab came in, that it was a savior. After years, when bronchial thermoplasty became a savior, and now that bronchial thermoplasty is literally out of the game, benralizumab came in, and people now market benralizumab as a savior because it was given as an alternative to thermoplasty. Now it is becoming as the only therapy, no thermoplasty. So, is it really like the way it's being projected, or it's just an add-on therapy?
So I think biological agents gets very tricky, and I think we still have to wait for the official guidelines on how to, wean these biological agents and whether we can add a second biological agents on top of the first one. So that's one of the issues that we have, where one of the pathways are covered with one of the biological agents, but they can't have 2 pathways involved. So that's why it's hard to get insurance approval for 2 medications. One is difficult to prove the biomarkers, especially if they're on steroids and the biomarkers are low. So to answer your question, we started, like as you said, with Xolair, the omalizumab, and now, then we favored Dupixent or Dupixent more, which is an anti-interleukin 4, because most of our patients have nasal congestion, like allergy symptoms, like allergic rhinitis and asthma or atopy or eczema. So that's why we thought Dupixent will be a good option. Then sometimes over time, we change them to mepolizumab or to the benralizumab, over time. It depends on how their symptoms are, and we monitor their biomarkers over time to see if they are going from one endotype to the other, and if we need to change, from one agent to the other. Currently, it's very difficult to add another immunological agent. And sometimes these patients have rheumatoid arthritis and other rheumatological conditions. So they're already on another biological agent. So requesting the third agent, which is expensive, insurance will give us a hard time on that.
That's the problem here.
I think we are still waiting for the guidelines to come out on
most of
tapering.
the biological agents are not insurance approved in India, or it is very difficult to get insurance approval, and it is too costly for our set of patients. So the one good thing is now Xalar has been marketed under 10,000 rupees, so it's more easier. 10,000 is still costly for an Indian patient, but that is the cheapest biologics we have.
Good to know. Things will change. Like for us in NYU, we have specialty pharmacies. So if a small percentage is not covered, the specialty pharmacy has fundings to cover for the biological agents for the patients. So even insurance coverage is not sufficient to get the agent.
I think future will answer the question. Next thing, one more I wanted to ask you, this PD4 beta syndrome, does it have a survival benefit, ma'am, or the study is too early? We need to give time for the study to complete.
Yeah, I think we need to give time to see how it works. Because when nintedanib and pirfenidone came out in clinical trials, it's the same thing. They decline, they can slow the decline in lung function, but whether it halts the progression of lung fibrosis. This is only a 3-month trial, so we have to wait and see, like over years, if it will really make a difference in the care of IPF patients.
1, 2, 3, with every trial, it over a period of time, it has been finally proved that survival benefit is very minimal. I think also it's more or less the same. We market it only as improve in clinical outcomes or improve in 6-minute walk test, improvement in DLCO. But when it comes to progression survival, it is like when you take it for next 5 to 10 years, after a period of time, it is more or less it's same in IPF patients, whereas it's good in CDLs. So again, that's why maybe it's too early to comment on the survival.
I think it's too early to comment on it. We started to use it. It's not a medication that we can order in our system. It has to go through the pharmaceutical company to get it still, because it was FDA approved. Yeah, later last year. So it takes time to get into the system.
Fine, thank you. I think.
And you might be using these agents in COPD patients too, right? We use the anti-TSLP in COPD, like if there are frequent exacerbations and frequent hospitalization, that's something that we are using in these patients.
Yeah, this PD for roflumilast was used extensively in COPD, but it was withdrawn to stop only because of GI side effects. It was very bad. Patients experienced severe gastritis to diarrhea and all mucositis, and literally they were happy to be on hypoxia rather than be on roflumilast with gastric side effects. So we had to shift to some other drugs. So roflumilast was literally stopped only based on the patient's side effects, and GA was really horrible in those patients.
It's the same for IPF and phosphodiesterase inhibitor, the GI side effects. With nintedanib and pirfenidone, sometimes patients are hospitalized with failure to thrive, because they keep on taking the medication because they know IPF is a dangerous diagnosis to have, but they end up with failure to thrive, which is then the survival goes down.
Yeah, I've seen patients with both mucositis, extensive diarrhea, literally going into no food intake for 2 weeks and admitted for fluids. So that's a different story on nintedanib completely. Fine, ma'am. I think
I was telling Dr. Manju that I'm not a basic science person. I do basic science as part of clinical treatment.
It's not an issue at all. We like what Dr. Madan Raj told, we came to know the latest definitions, the pathogenesis mainly, the role of inflammatory markers, everything. That's all part of it. And you have just correlated
Thank you.
to it. And it was nice hearing my dear friend speaking on this forum. And any questions from the delegates? Can you see anything, Dr. Madan Raj? They might
There's
have
nothing in the chat box.
because from the
In my
delegate.
chat box, I'm not able to see anything.
Okay, and the delegates are in a different group. If something is there, it will be pasted into your chat box. Can you see any questions? No.
No, my chat box is on.
So I think let me
Okay.
see my chat box. Yeah, there's nothing there. Okay. So I think we'll wind up with this. I think yes, anyhow, let me, before winding up, thank both of you, Dr. Manju and Dr. Madan Raj, both coming together and making this 45 minutes a real good scientific experience or a very rich academic experience it was. I hope all the delegates would have got advantages from your talks and the latest, the recent advances in the management of all these three diseases also. So thank you very much. Though it's on a virtual mode, we would like to first honor our resource person, Dr. Manju, by a virtual certificate and a virtual memento.
Thank you. Thank you so much.
Okay, next I would like to even extend my gratitude to Dr. Madan Raj for spending this 45 minutes morning with us and chairing this session. Thank you, Dr. Madan Raj.
Thank you.
So once again, I thank both of you. Great seeing my two friends together on the screen. Bye.
Good to see you there too. Okay, thanks, Dr. Madan Raj. Thank you.
Thank you. Thank you.
Bye.
Thank you.
Thank you, respected Dr. Manju ma'am and our esteemed speaker and chairperson for that excellent session. We now move on to the anatomy session. The topic for the session is simulation in anatomy, competency-based medical education. I now invite the moderator.
Ma'am, you are not audible.
Yes. Hello. Hello, Dr. Jayashree. Good morning.
Can you hear
Dr.
me?
Yes.
Can you
Good
hear
morning. Yes, I'm here. Good morning to all of you. I think moderator will join soon. Sir,
Yes.
Dr.
Maybe some network problem. We'll see.
Hello, do you able
Yes,
to get Rajan here? I'll just
Yes,
find
sir.
out. 1 minute, ma'am. I'll just find out what the issue.
Yes, yes.
we are waiting for the moderator to join, ma'am.
I'll moderate. There's some issue with the.
Yeah, please, sir. Okay.
A very good morning to all. I'm Dr. Rajan here. I am very happy to introduce our moderator, Dr. Jayashree Abram and Dr. Manisha. They have been associated with me for long times, and they used to join for this conference frequently, often. And So Dr. Manisha is a professor at the Department of Anatomy from AIMS, Rajpur, and she is having more than 16 years of teaching experience in anatomy. and also member of medical genetics unit in AIMS Rajpur, member of medical education, and also awarded fellowship of International Medical Science Academy in 2022, honored as a member of National Academy Medical Science in 2020, and she's also held the Presidential Award by a National IMA in 2020. She received Rashtriya Gaurav Award in IFS on 2019. So she has so many publications in national as well as international journals. She also co-director or the founder of the Forum Jeevan Foundation. So this is about Dr. Manisha. Now I'll just give some few words about the Dr. Aribam Jayashree Devi. She is a professor of Institute of Medical Science, Impal, Manipur, and she has experience of more than 50 member of IMA, ASA, SOSA, SOMA, almost all the anatomical societies. She is the organizing committee of, she was organizing committee of the 62 NAFCON 2014, and reviewer of Saroj Journal of Medical Science and Journal of Medical Society. She has a lot of publications in the field of morphogenesis of various fetal organs, dermatoglyphics in DM, CA breast, and as well as anthropologies. And she also done a lot of publications, more than 30 in national as well as internationals, in 6 publications. This is about her credits. Now I'll hand over the forum to Dr. Manisha and Aribamshi for introducing the resource persons. Dr. Sri Sir is very known to me. When I was doing my PG, Sir was a senior resident at JIPMAS. So, Sir, thank you so much for joining this forum on behalf of for my request. Thank you, sir. Ma'am, over to you, ma'am. Sir, the resource person.
Yes. I'm muted, sir.
We are able to hear you, ma'am.
Sir, I am muted.
You are audible. You are audible, ma'am.
I'm audible? Okay.
Yes, yes.
Sir, please share the stay contested, sir. Hello. Manisha, ma'am, you are muted.
Yes. Sir, very good morning and great thanks to you, Dr. Rajan, and for inviting me. And we know our well-known Dr. Sri Kanteswara Vishwanath Reddy. It's my pleasure to introduce Dr. Vishwanath. He is professor and chair of Department of Anatomical Sciences, Antique, American University of Antique, and he is graduated from Mysore Medical College and post-graduation also from the Mysore. He did his post-graduation from Mysore Medical College, University of Mysore, and he is program director for AMSA community screening for diabetes and hypertension, glaucoma, breast examination. He is program coordinator for AIDS prevention unit, South Sector, St. Lucia, and he has he is presently professor and chair of Department of Anatomy, American University of Antique, and he is he has introduced wet lab assessment. His contributions are he did under guidance of ex-dean Dr. Nigra established the present skill and simulation lab. He introduced simulation curriculum with guidance from ex-ICM chair. He is appointed as a theme director, implementation of skills and simulation program. He has a chair for year 2024-25 he introduced second sim case for semester 5 BSIS, lab activity creation organ system for anatomy labs, guided faculty guidance research, assessing ultrasound simulation role in CVS anatomy learning at a Caribbean. So this is the long list of introduction of Dr. Vishwanath. Now I would like to invite Dr. Vishwanath on the topic simulation in anatomy, competency-based medical education. As we all know, simulation-based learning is transforming medical education by bridging the gap between theoretical knowledge and clinical practice. Over to you, sir. Dr. Vishwanath, sir.
Yes, ma'am. Thank you. Thank you for this introduction and a very good morning to you all. Right now, the time here is 12:30 and I'm really surprised. I mean, after 25, I think 26 or 27 years, I'm seeing Rajan. I don't think he's been aging at all. He's been so young since then. It's very nice to see you, Rajan. Yes, I was also hearing the sleep specialist from New York at the same time here also. So let me just start off with my presentation. Um, Let me just get this down. Okay. Yeah, this is my medical school. It is situated in a very small island, which is not even on the map properly. Only this is the Antigua and Barbuda. It's a very small island, but very famous for its 365 beaches. And this place is just 43 miles and maybe another 35 across miles, such a small island. Anyway, being here, it's my privilege to work in this medical school because I've been exposed to so many things and I have also brought in all what is required for our students. Basically, our students here they do their basic sciences, which includes preclinical and paraclinical, the equivalent of that in India. And then they go on for clinical rotations in the United States. So, how host is spotlighted your video for everyone. Okay. So, from this beautiful Caribbean island, uh, it's my privilege to talk to you all. And let's start off with why we have simulations. Why simulation in healthcare? And in particular, why simulation in anatomy? Of course, simulations, all of us are very much, we all know about it because we've all traveled in aeroplanes and we feel safe. We don't even think about anything of untoward. It's all based on that simulation which the pilots are trained. Having that as an analogy, we want to see how we have done in healthcare. So having said that, so simulation, the most powerful pedagogy, learning and practicing psychomotor skills on high and low fidelity mannequins. Simulation takes teaching and learning to the next level and the iterative level and deliberate practice. This is something from the literature. Here, both student and teacher learn. The former about the complex world of practice in a safe learning environment, and the latter about how students perceive, think, and respond to the complexity of practice situations. Now, my talk here is more about what are the things we have introduced for our students and how the students have been benefited in their long-term education. The thing is, we here are dealing with pre and para, but at the same time, we need to give them clinical exposure so that when they go to the hospitals for their clinical rotations, they are competent with their peers. So we have geared up to bring in all possible simulations and simulation kind of activities, which I'm going to elaborate as we go along. This is just an important uh, uh, chart, which I'm just displaying to you all. In an undergraduate medical school, here we have the novice, not allowed to practice, but is still seeing and is observing. And this is a little bit as you go up the lane, which is basically in the latter part of the preclinical and the beginning of the paraclinical. He's going to have to practice with full supervision. And then he goes on for clinical practice and for residency and fellowship. And in this, he is going to become competent, practice with supervision on call. And then we go on to the proficient, which is practice without supervision. We want them to be here. That's the recommended medical education goal. And of course, expert, they're going to be like the previous speaker. The experts are going to be, they are going to supervise the novice and the advanced population. So having this, one of the key words we need to understand here is deliberate practice. We need to practice with our consciousness. And this is important because it's not just practice, it's to practice so that we can improve and our student population will get the most of it. A little more on this is going to be from a passive learner, how they're going to be educator-led practice or skill, where the learner observes, and then educator and learner takes equal roles in guiding learning event, and then student-led active learning, educator passive during the simulation scenario. This is a little bit important. The educator being passive is going to be very important because even if they do it right or wrong, it's at that point in time, we're not going to disturb unless and until if it is a critical situation. But then we're going to debrief the students. Debriefing is after a simulation session is over, we are going to sit with them and we're going to discuss what they did, what they know, what they did not know, why it went that way. That is where uh, they get most out of it. And of course, we all know about this experiential learning, and that's the platform we are using in simulations. For example, we have intramuscular injections, venesections, cut down, intravenous access. All of these are some things which is everyday physician activities. This is another important slide, which is basically showing how the novice, in his confidence level, he has very little confidence and competence, of course, nothing. But as he moves on, he's going to get some confidence and a little bit of competence. But then in advanced, he's going to have most of the confidence and the competence, but still he is hesitant. But then as an expert, they have both. So basically, this is the graph which has been showing that at the intermediate level is where the peak of this activity is. And that's the gap between the low and the high learning. To start off my journey, as it was said in the introduction, I was just in anatomy, teaching as we go along. We just had small group case discussions, nothing more than that. But then the dean, Dr. Nagra, who was a military officer, to his credit, he has worked on malaria in Andaman and Nicobar Island, no, sorry, Lakshadweep Islands, and has controlled the mosquito menace. And he has been awarded the national award, the highest award in military. So he told me to just go on and establish a skills lab and a simulation lab. And he said, funding is no problem. We'll get the funding for you. Go on. I said, I don't know anything. And he said, well, I'm there to guide you. And he was previously the dean in Malaysia. And just as a background, I want to let you know that this school which I'm working now is a part of the Manipal group of institutions, where he was the dean in Malaysia. Malaysia has a medical school there. I mean, Manipal has a medical school in Malaysia, where he was the dean and he has set up a skills and simulation lab. So based on that guidance, I wanted to learn, but I did not know where to start. And then out of my search, I came up with this simulation center for medical simulations in Boston, US. Those who are interested in medical simulation. Now, this center is known for everything, but more so, they've done a lot of research on debriefing. That is, having a talk with, and this is how we have a talk with our students too. It's going to be just a round table so that there's no senior, there's no junior here. We are all equals. All of us are here to learn. So, having said that, well, this is something which this is another center in New Orleans where I had been. I just want to show you, those who are in anatomy, I want to show you that this is, of course, this is one of the labs. It's a simulated lab here, but this is a operation table with X-ray, everything in it. And when we went there, this hall, so to say, had 35 tables. And of the 35 tables, only on 5 tables, cadavers were there. And then I was shocked to see that such sophistication is being used on cadavers. But then I learned that during that Katrina hurricane period, the whole city of New Orleans was immersed in water. So at that time, they came up as a solution. They built a whole hospital, but not a running hospital. It is going to be a makeshift hospital. That means any of these such emergencies come, they're going to transfer that right away into a complete hospital. So that is the kind of care they have now come up with. So now, in our institution, having done all of this, of course, I'm not including the simulation, the SimMan 5G, what we are doing. We have a big program on that. I'm the coordinator of that program. We have, since we are teaching in each system, we have 2 cases, and we ask the students to go through these cases. May it be um, diabetic ketoacidosis or just asthma, or maybe a myocardial infarction. And that's a big story. But in anatomy department as such, we've introduced ultrasound simulations. Now, this is a game changer for our students. Ultrasound simulation. Here we see our students who are basically having the probe, and they're looking at the images here. And in addition to this, they have this Microsoft lens also, which is going to give you the 3-dimensional effect of the vision which they're going to be seeing in this mannequin. So this is something which was very, very interesting. And we had to come up with our own knowledge of ultrasound, which basically anatomists don't have that much. But then we had a dean at that point of time who was also a radiologist and an OBGYN specialist. So he basically has helped us, and he is for our whole department, which was at that time we were around 14 of us. For the whole department, he took us boot camps. Boot camps twice a week. We are on the hot seat. He used to show us images, again show us the images. And the whole of radiology we learned under his leadership, Dr. Graham. So having done that, we also have, this is the augmented reality with these lenses of Microsoft lenses. Here, what we have is a combination of real and virtual worlds, a real-time interaction, and a 3D registration of virtual and real objects. So this was the game changer which I was talking about. Here in this picture here, when they're when they are scanning the patient, we see one side the anatomy, the ultrasound of it, and on the other side, we also see the anatomy of it. So it's very easy for our students to learn. Now, one step ahead, we went on and we started training our students with real ultrasound. So our students, though, remember, we are only catering to pre and paraclinical, but our students got the hang of it. And here in this case, they are themselves doing the scanning of their peers. And completely, this was mind blowing for us that they have taken interest. And here we have our in-house radiologist, Dr. Eli, who's also helping them and guiding them. So we have two mannequins of ultrasound and two real ultrasound, which is how our students are progressing. Because one of the things I do have is these students have to take exams, which is step one. And then subsequently, after the clinical rotations, they have to take step two. So during that period, they have a lot of ultrasound in their clinical vignettes or in the exams. So they have to be thorough in this. So that was one of the reasons. And more importantly, you go to any field, nowadays, we don't wait for the radiologists. We do the scanning ourselves and send it to the radiologist. So either it's going to be any your general practice also, whether you're OBGYN or whether you are an cardiologist, whatever it is. So it is made all doctors to learn simulation ultrasound as an essential component of their practice. Again, these are some of the pictures here and some of the students. We also have a ratio of 8 students for one lab, one faculty for each. And this is our radiologist from town. He's been here for a long time, Dr. Raghunandan, and he has also been helping us in real time teaching of the real ultrasound. Now, the whole part of this is today we all are having a stethoscope, but tomorrow's world is going to change. As a matter of fact, it has changed in the United States in all the big universities where they're given probes. So here you see that the student or the doctor maybe is scanning the patient and is getting that directly onto the mobile phone. And once they get a video or a picture of it, they can send it to the ultrasound. They can send it to the specialist. And so this has helped tremendously in especially diagnosis of pericardial effusion, tamponade, and of course any fluid, hemoperitoneum, as in the case of a fluid accumulating in the hepatorenal pouch of Morrison, and of course in pneumothorax. Intervention can be started off even before the patient reaches the hospital here. Having gone through this, we have now gone one step ahead, and this is what is known as the FAST program, focused assessment with sonography for trauma. This is where we scan the patients in the field, whether there's an accident or any of that criticality. What we do is, this is where this previous slide comes into place. So they scan, take it onto the phone, WhatsApp it to their bosses, or they make the diagnosis right away to whether put a needle or whatever required. So this program has um, helped our students a lot. And having that in mind, we have now created what is known as peer-to-peer ultrasound teaching, in which the senior students who have learned and been certified, we certify them, or who have certified, they teach the younger generation of students. It doesn't matter if they're in any semester. They are going to be taught by their seniors who have been certified. So this is the FAST program, which is, of course, very common in the United States, and I wish it's going to be also coming coming quickly into India because we have a large population and a rural population where um, medical health and medical care can be given on the field itself. Another area where we got into our simulation hat is ophthalmoscopic examination, ophthalmoscopic and otoscopic examination. Here, again, you see that this student is looking at her peer's eyes. Of course, I'll tell you about this instrument. But before they do that, we first expose them to a mannequin, which my colleague here is showing the students. And once they see and are comfortable in keeping the angle and the way they have to use the ophthalmoscope, we then ask them to see among themselves. So what we are going to be seeing is the retina and more important is the macula, where we are going to see the central artery of retina. So here again, we have been trained, and training was done by the local ophthalmologists, and both of them are the specialists here who has trained us for training the students. And that is something which we have been very appreciative of, even if it is for radiology or this one, we get their expertise and we learn from them, and then we go on to teach our students. Well, I was talking about this instrument here. This is the pan-ophthalmoscopic instrument. Of course, here this is the Welsh Allen pan-optic ophthalmoscope. Now, this is something which is a game changer in today's world. The reason is when we want to see the retina, we basically have to dilate the pupils. But in this case, we don't need to dilate the pupils. So that is going to be the game changer. And it has 20 times better resolution. So many of the ophthalmologists are using this now before they use the other instruments. And again, this can be hooked on to a mobile phone, and you can take a picture or a video and send it. If you are not competent enough, send it to the specialists. In this case here, yes, you're looking at the students who are looking at the mannequin first, and then over here they're looking at each other's eyes. The reason why we started this in first year itself is we have in our clinical medicine courses, we have what is called a standardized patients, wherein a person is trained to be a patient, talk and give the history, and then allow themselves to be examined. So in the process, if say the patient has diabetes, if they have hypertension, can they look into the eyes? Yes, the students must start off in first year. As they proceed, we are going to have 5 semesters. By the time they're fifth semester, they're very, very easy in handling these equipments. That's the idea. So this was introduced very early in time and is progressing nicely for us. And these are some of the visuals in our skill lab. Another big game changer is this peak acuity. All of us just search on Google peak acuity and you can see how much of power the person has, in the sense the lenses required for them, or the spectacles which is required for them. Used in medical camps to cover large number of people as a screening tool for visual acuity. Now, this is something which has been a game changer in India. This is because I know, because my friend who is an ophthalmologist in UK and he's a very dedicated person. When he comes every time to India, his friends organize some villages, and in these villages they go on screening their patients and giving them whatever required, if wanted, so spectacles and medications. So this is something which is very useful. I want you all, it is very, very easy to learn this. I want each one of you all, I don't know how many medical students are looking at this um, presentation. Please go through this. Everybody was going to be amazed to see how it is. It's very, very easy. He is just showing the signs of how the E is. Now the E is directed to this side, and then they're going to that side, this up and down, and that's all it is. Another important thing which I have personally brought in is the importance of escape rooms. Escape rooms, I know some of you all might have it in their towns or in their cities. I think Bangalore has two escape rooms where you go into a dark room and there's going to be ghosts and they have to scary music and all of that, and they go on to um, scare you, but you have to solve a puzzle and you have to come out in a particular period of time. So what has happened is we have, I myself, for this, the theme is escape room for hypertension. We have used a hybrid method. We have used the Harvey mannequins, the cardiorespiratory mannequins we have, and I've put in a scenario. The goal of it is to escape by solving puzzles related to hypertension within an hour or so, set as the limit time. Storyline: you and your team are medical students trapped in a high tech sim lab. You need to diagnose and treat a 45-year-old patient with hypertension before time runs out. Solve the puzzles and unlock the clues and find the treatment protocol to the escape room. And this is now going on for the third consecutive year. That means it is 6 times. So every 6 months is one semester. So this is done in the in our sim clinic. They must go through 3 rooms to solve these puzzles. This is a little bit toned. 3 rooms, and now I've kept the same escape room for hypertension, but 3 cohorts are going to be there. So who comes out first will be the winners. Simple things like once the team which comes out first, we have 4 to 6 people in one team. If they come out first, we give them a movie ticket, or maybe we give them, movie ticket and a pizza party. Here, pizza is very common. So, and of course, as I said, I have not touched upon the actual simulations which we do for our patient, for our students, which is each system we have 2 cases which they have to go through. And we have introduced one for the 5th semester also, neuroleptic malignant disease, and of course gallbladder, which they have to scan. So having said this, I think another one important aspect about is the handled ECG, the heartbeat monitor. Now this is also another game changer, which is in very commonly used nowadays, and to identify if there is any emergencies, as it's shown here. For example, if there's an inferior wall MI, immediately you're going to see this in 2-3 AVF, and then do whatever is necessary for our patient. Because again, time is the factor in all these emergencies. Reaching the hospital in time is a matter of saving their lives. At the last, I just want to say, I'm not going to be saying this. This is said by Emerson. Do not go where the path may lead. Go instead where there is no path and leave a trail. Thank you very much. So this is my presentation here. I'll stop sharing my screen and I'll take some questions.
Thank you, sir.
Yes, ma'am.
Thank you. It's wonderful.
Thank you so much,
Welcome.
sir. We
Welcome,
are deeply
welcome.
grateful.
Please go ahead.
Am I audible?
Yes, ma'am.
Am I audible?
Yes,
Yes,
madam,
ma'am,
you're
you are.
audible.
Am I audible? Manisha, am I
Yes, madam.
audible?
Yes, madam.
Thank you so much, sir. We are deeply grateful for your illuminating presentation on simulation in anatomy in CBME. It has provided us with useful, effective, and productive methods in learning anatomy. And many of them are very new to us, sir. Though we have known
Yeah.
ultrasound, ophthalmoscopy, you have added in the first year. Thank you so
Yes.
much, sir, for your
And
sharing your extensive knowledge in this field, sir. Thank you,
yes, I
sir.
just also wanted to add some important point for those who are wanting to go into genetics. We have one of our colleagues from JIPMA, Rajan knows him very well, Dr. Giri Raj. He's in Nagaland, and he has opened from the government of India, he has opened the best genetics lab in the whole of
Yes,
India.
sir. Sir Giriraj is in Assam, sir.
Assam, sorry,
Yes,
Assam,
Assam.
not Nagaland, Assam, Kusri, Giriraj Kusri. Rajan would vouch for that. Very nice gentleman.
Sir, Dr.
Rajan, you remember
Manisa,
him?
my co-chairperson, also working in genetics.
I visited his lab,
There we
sir.
go.
One time I went there. He
Uh-huh.
invited me, so I went there.
Oh,
Yes,
oh,
sir.
nice. Oh, nice.
Sir, a
Okay.
few things are very new to us. That theme of escape. These are new. What we do in this theme of escape, this is related to hypertension. What we do here, we solve the puzzle. How we proceed for that, and why we are doing
So,
this.
escape rooms, the main thing is, of course, knowledge delivery, knowledge appreciation by the students. They have learned everything in the textbooks. But when they are put into a time constrained environment, they have to come up with the answers and their thought processes. So what it is, for example, hypertension, what I've done is once they go into the room, they have to first identify what the blood pressure is. So in that, how we can increase or decrease the blood pressure, keep it normal. We can do all of that. And once they get that, then I'm going to ask them to which JNC classification does that patient belong to. So once they know that, now they have to identify if uh, the cardiovascular system is normal in this patient. Look at their JVP, look at the apex beat, look at the carotid upstroke. All of this, they have to come up with a particular thing. And then if there are any valvular abnormalities, all of that. So once they do that, next is this patient has come from the field. That means he has been dehydrated also. We're going to ask them what type of drinks would you want them to give immediately, if not IV. So we keep them Coke, we give them water, we give them coconut water, everything. Well, they have to choose coconut water for that in that case. So once they do that, then they move on to the next part of it where they have to come up with what are the risk factors for this patient. And then they have to come up with the treatment. So all of this, once they know that, we have I don't remember I forget that name of it. There's there is a website, an American website, where the doctor fills in all these details and it gives a summary of what should be known to the patient. I can send that later. I'm forgetting this off the top of my head now. So what they do is once they fill in all of that and come to know the risk category and what they have to avoid, what they have to take, medicines, everything, then they're let out of the room. So this whole thing in this kind of time constrained period is going to give them goosebumps, so to say. Yeah.
Thank you, sir. One question is in the chat box. Can I ask a question?
Yeah, sure. Yes, ma'am. I'm not seeing the chat. Please go ahead.
They want to ask actually
Yeah, please go ahead.
directly to you. The chat box is written. Mr. PK, I think.
Ma'am, another question about that.
Uh,
not able to see that question.
Okay.
Okay, the first one
Dr.
is
Jayashree,
Gopinath,
are you able to
HOD
see
of
that
Physiology.
question?
Nice talk, sir. We have tried using escape rooms and teaching physiology students take up difficult concepts in a very interesting manner. It mandates a lot of time for our faculty to create and execute. Have you used softwares to create such assessments? Yes, sir. We have used the software which I have used is iSprings. iSprings is something which we all can have. We can buy it on subscription. We can create all of this. For example, as I said, a simple example of what I'm saying, not the treatment, as far as the water, the Pepsi, and the coconut water, all of this, they have to take at that and move it to the respective box. If it is correct, it will stay there. Otherwise, it will jump back. So this is something, and one important thing about it is escape rooms running it in a lot of when there are students of 100 or 120, it's literally difficult. That's the reason why I introduced it to the global health teams. Global health care is something which we have as a part of our program where only few students come in. So in global health track, these few students, we have 25 or so, it's easy for us to run this. So yes, Dr. Gopinath, it is difficult to run it for a large groups. It takes a lot of time, but again, once executed, you may have some faults. You are going to rectify that again. Keep on running this many a times until you all become familiar with it and competent with it. Um, that's all I can say for now. If you have used it, you know the details of the difficulty. Let me go to the next one. Dr. Gopinath, did I answer your question, or Dr. Gopinath can come in if he's can unmute and talk.
Sir, it's
Okay.
our pleasure to chair the session. It's wonderful work, sir. And I would like to Dr. Rajan, please take over.
Madam, yes, madam. Good evening, sir. Thank you, sir, Dr. Vishnunath, sir. It was very good presentation, and really it is useful. And most of the UG students are here, sir, and you enlightened them. So hope it will be useful
Yes.
for all the students, sir. Thank you so much,
Yeah.
sir. And thank you, Dr. Jayashree Aribam, madam, for chairing the session and very good night discussion. And thank you, Dr. Manisha, madam,
Thank you, sir.
for chairing the session. And on behalf of organizing committee, it's time to appreciate. So we appreciate, sir, by giving certificates and memento to Dr. Sri Kandeswara Vishnunath, sir.
Thank you very much.
Kindly.
I'll give this. I'll send this presentation to Dr. Rajan.
Yes,
if
sir.
you want, he can share it with whoever is interested, so that
yes, sir. Sure, sir. Sure, sir. We'll do it, sir.
Thank you, sir, for that.
Thank you so much, sir. Thank you so much. It will be useful for all the delegates, sir.
Yeah, thank you all very much.
Now it's time to honor our chairperson, Dr. Manisha B. Singha, madam. Thank you, madam. Next. Thank you. It's time to honor our Dr. Chairperson, Dr. Aribam Jayashree Devi, madam. Kindly accept, madam.
Thank you, sir.
So once again, thank you, sir. Thank you, madam.
Thank you all. If you all want, my email address is there. You all can communicate with me also.
Yes, sir.
Thank
Sure,
you.
sir. Thank you so much.
Thank you, sir. Thank you, ma'am.
Thank you all. Bye, Rajan.
Yeah,
Take care.
Manisha, ma'am. Thank you. Thank you all.
Rajan, thank you.
Thank you.
Thank you.
So we'll move on to the next session, sir.
Thank you, our esteemed speaker and chairpersons, and Dr. Sridhar sir and Dr. Rajan sir for joining us. Thank you, sir. Now we proceed to the next session, Physiology. The topic is nitric oxide directs tip leader cells forming blood vessels. May I now request our moderator, Dr. M. Gopinath sir, our organizing secretary, Professor and Head, Department of Physiology, Avmc, to kindly take charge of the session. Over to you, sir.
Hello, am I audible?
Yes, sir.
Hello.
Hello. Am I audible?
Yes, sir, you're audible, sir. Sir, just a second, sir. Dr. Gopinath sir is joining. We will start once he has joined, sir.
Yes.
Hello, am I audible? Good morning.
Yes, sir. Good morning, sir. Sir, you're audible, sir. So, sir,
Okay.
you're audible, sir.
Thank you.
Yes, sir. We'll start in 2 minutes, sir.
Yeah, sure. You take your time.
Am I audible, sir?
Yes, sir. Yes, sir.
Yeah. Good morning, everyone. Welcome to the scientific session at BMSC Con. Welcome, sir. It's my extreme privilege to welcome our chairperson for this session, Dr. Tirupati, sir. And I welcome our resource person also, Dr. Suvro Chatterjee, sir. It's my privilege to introduce our chairperson, Professor Dr. C. Tirupati. Sir is working as a dean at Sri Satya Sai Medical College and Research Institute, SBV Chennai campus, Chengalpattu district. And he is a veteran medical academician and healthcare administrator with a 35-year legacy in a government health and family welfare department of Tamil Nadu. And he has successfully steered major institutional transformations and holds deep expertise across all 3 tiers of the state public health system. And sir served as a special officer cum dean, playing a pivotal role in its government, Raja Mutaya Medical College, and ensuring full NMC compliance for many years. And served as a former director of the Institute of Physiology and Experimental Medicine at Chennai. And he has a clinical interest towards clinical physiology, digital sleep medicine, neurophysiology, and non-communicable diseases, and towards administrator as towards public health services also. Sir has established advanced clinical physiology laboratory and services at MMC, and he has highly experienced as an university examiner, inspector, and NMC nodal officer also. So we are happy to have you here as a chairperson today, sir, in spite of a busy schedule. Over to you, sir. Take over the chair.
Thank you, Dr. Gopinath, for your nice introduction. I'm very proud of being the part of this team. Let me introduce our speaker of this session. I have the privilege to introduce Dr. Saurav Chatterjee. Is a UGC FRP professor, Department of Biotechnology, University of Burdwan, Golfbagh campus, West Bengal. The University of Burdwan, West Bengal, is working there in West Bengal. Before joining the University of Burdwan in May 2021, he was in Anna University and coordinator, Life Science Division, AUKBC Research Center, Chennai. Oh, here in Chennai, Anna University, he has been there in another university for a long 17 years. Saurav Chatterjee's research interests revolve around nitric acid signaling in endothelial bed and vascular remodeling. The goal of Chatterjee lab is to understand the role of nitric oxide signaling pathways in cellular migration, permeability, and angioneogenesis. He is BSc 1989 and MSc in Human Physiology from Calcutta University. Is completed in 1992, trained as a cell biologist at Devi Hakilya University, Indore. He has done PhD in 1999 at McGill University between 98 to 2000 and Mayo Clinic, Rochester between 2001 to 2004. Postdoctoral trainings he has completed there. He has 140 research articles published in peer-reviewed journals like PNAS, Circle of Respiratory, American Journal of Physiology, American Journal of Pathology, British Journal of Pharmacology, and Journal of Cell Sciences to his credit. Dr. Chatterjee is the first recipient of UGC Faculty Research Program professorship in life science and accordingly joined the Department of Biotechnology, Anna University in 2014. He is also awarded with Wood Whelan Fellow, IUB MB in 1997, MCBN, UNESCO Research Fellow in 1998, Dr. Alan B. Hawthorne Award, McGill University 2000, INSA International Fellow Award 2014, Swiss National Science Foundation Award 2014, and Fulbright Nehru Academic and Professional Excellence Fellowship in 2018. Presently, he is acting as member of SERB, Core Research Grant Biomedical and Health Science Program Advisory Committee, CRG, that is BHS PSC, since 2022. Welcome you, sir. We are eagerly waiting for your topic. This is very much interested topic. We are going to be updated on your research findings now. We are eager to listen your speech. Thank you.
Thank you very much, Professor Tirupati. Am I audible?
Yes, audible, sir.
Oh,
Please
thank
proceed.
you. Thank you very much. And it was very long introduction. And okay, now I'll be trying to start. And also thank you, organizers for inviting me in this occasion. And I hope there will be lots of students, young students are there, undergraduate, and basically I really want to interact with them. And now the topic, first I will try to share this screen. Just so, is the screen visible?
No, sir.
Just one second. No?
Yes, sir.
Yes, sir.
It's starting.
Yes, you can put in slideshow mode, sir. Yes, now it is visible, sir.
Okay. And in between, if any reason like technical reasons, if get stopped or I'm not audible, in that case, just send me some indications that I'm not audible.
Yes,
So
sir.
that
Yes,
will
sir.
be, yeah. I hope everything will go well.
Yeah.
Yeah. So the topic is particularly, so I'll be focusing the whole thing towards the young students. So nitric oxide directs tip cell, leader cell forming blood vessels. It would be a bit, I think, a bit difficult title for the young students at this moment of their career. So I'll just introduce it from the very introductory way. So first, I like to tell students it's very fundamental aspects of life. You know, when we consider, means which is the very basis of, because physiology professor is there and students, you already went through physiology. I think first year, second year already over for you, and And now for the when it comes to physiology or the function of yeah, when
Technical team, please mute others. Please mute other people.
It's done, sir. So please unmute your mic, sir. Your mic also got muted, sir.
Yes, sir. I unmuted.
No, sir.
yeah, it's okay now.
Yeah.
Please unmute yourselves. Yeah.
Yes, sir. Yes, sir.
So when we are talking fundamentals of life, then very fundamentals of life, then there are three pillars of fundamentals. One is cell growth, volume, mass has to be increased. That is the growth. That is the in a very much better way if we speak in a language, our language, then we call it proliferation. The second part is the migration. After proliferation, the system needs to get migrated from one place to another place, or to extend one's hand to another hand. That is also called migration, to interact with each other. This is the second pillar. And third pillar is the communication with outer world. That means the cellular system is there, or tissue system is there, or the human being is there, animal is there, whatever it is. Standalone human being, standalone one single cell, standalone one single plant. So they need to communicate to the outer world. That is the communication. And that communication, in a very fundamental aspects of that communication, is the cellular selectivity. That means some molecules we need to get inside the cell, some molecules I need to expel out from the cells. That process continues. So now if you combine all these three processes, that is the proliferation, second one is migration, and third one is particularly the communication. That means crosstalk with outer world. It can be cell to cell crosstalk. It can be human to human crosstalk. That means we are now at present I am communicating with you. This is a crosstalk. My neuronal system, neuronal network is coming up in a such a way. I am talking such a language that you all people can understand. This is communication. I am not talking something Chinese or something different language or my own language. So you cannot understand. So in a very, very programmed way, we are going to communicating each other. This is the communicating to the outer world. And now we are talking about neurological network because we are speaking, and you can assimilate in your brain. That is one part. In the similar communication is also happening at molecular level. That means some protein, transporter protein is transporting glucose from outside, from inside of the cells to outside, from outside of the cells to inside. This is also communication, communicating to outer world in a similar way with the way we are doing biological network, that is neurological network, when you are speaking, when you are communicating. So when these three aspects coming together, then life turns into in a different way. Okay, it goes left, it goes right, it goes X, Y, Z, all movement, and there will be some meaningful outcome. Gradually it comes, and higher functions comes. Function comes that higher functions means you are talking about, for example, you are talking about one blood cells, white blood cells. White blood cells is suspended in your blood. This blood is contained in blood vessels. These blood vessels are perfusing every tissue, and every tissue is different. That means our brain tissue is different than the liver tissue. So liver vasculature and brain vasculature is, and being a medical student, you know very well. So your brain vasculature and the liver vasculature, they are different. Demand is different. So you see, fundamentally, we are all talking about cellular fundamental components, proliferation, migration, communicating, to each other and getting something meaningful. Once we got the meaningful thing, then we have different challenge at higher level. And higher level is that blood has to be properly saved in a particular conduit, that is the blood vessel, that is the vascular system. That vascular system has to be propagated, that means blood has to be propagated, blood has to be pushed to go from one place to another place. For that we need a pumping station, that is the heart. So vascular system evolved. So as the higher functions are coming up, then challenges are different, and we are meeting those challenges in a very similar way. In a very similar way. Now I told the perspective. Now in a very similar way, now I am coming down to a particular point that is called blood vessel. And you know, when blood vessel is getting formed, then that phenomena in a very generic way, it is called angiogenesis, blood vessel formation. And then when you are in embryo, then we call it vasculogenesis. Then there are different kind of blood vessel formation, but generic way, in a very popular term, is angiogenesis. Let us stick to that point, angiogenesis. And once we are telling angiogenesis, when you are defining angiogenesis, then angiogenesis can be in a different ways. Okay, different ways. There are 4-5 different ways angiogenesis, that blood vessels forming, the formation of blood vessels can be done in a different ways. And instead of going into details of it, only few names I can tell you. One kind of blood vessel formation is called sprouting. Another kind of blood vessel formation is called intussusceptive angiogenesis. Another kind of blood vessel formation, parallel duct. So there are different kind of blood vessel formation depending on the situation, depending on the physiological and health situation. Blood vessels are getting formed in a different way. So now I just described that what is angiogenesis, blood vessel formation, and also very important for all of us, including a clinician. It's very important to know blood vessel formation is so fundamental to life that it requires during the embryonic development. Any problem in the programming of blood vessel formation during the embryonic development, it will cause different kind of malformation. It can be it can be like teratogenic effects of different kind of drugs and different kind of molecules. You know, there are different kind of malformations happened in the even in human, in animal as well. So a different kind of malformation, that's called teratogenicity. So in most of the teratogenic conditions, there will be screwing up of the blood vessel formation in that particular area. So that is very important area. And then when we bring angiogenesis in forefront, then a huge area for angiogenesis research in very popular area, that is the tumor biology. So you know the concept of blood vessel and tumor, metastasis and tumor, aggressiveness of the tumor and the blood vessels. So blood vessels supply the supply route for the nutrition. The tumor will be getting nutrition and tumor will be getting bigger most of the time. It is not exclusive, but still, it's the most of the time tumor will be getting bigger with the blood vessels, and these blood vessels has to be gagged. When this blood vessel has to be gagged, there are a couple of drugs, very popular drug like Avastin, a drug which is the antibodies to VEGF, a growth molecule which is important for the blood vessel formation. It is the antibodies against the VEGF ligand. And when you use this antibody, then VEGF is getting shut off. And as it is getting shut off, then VEGF receptor doesn't get the VEGF molecule, and downstream signaling gets blocked, and the formation of nascent blood vessels is blocked. So it is very interesting, very some kind of interesting and very popular concept that if you gag blood vessels, tumor will be erased off. But it's not that simple. It's not that straightforward. But still, it's concept and it's some kind of validated concept. So now this blood vessel formation, you see, tumor needs blood vessel, embryo development needs blood vessel in health. Another big area for blood vessel formation is the um, wound. In any wound, when it is getting healed, it can be internal wound like stroke, any kind of stroke in brain or in muscle or in eye. So to recover from the stroke, the first point is there should be enough supply of nutrients to that area, damaged area, and then only blood vessels can do it. So there is a formation of blood vessel is very critical during the wound healing. That means wound healing, a big area, clinic is a huge challenging area, wound healing, particularly when diabetes is there. So blood vessel formation is very important, critical there. In tumor development, very critical. In embryogenesis, embryo development and fetal development, very critical. So you see, blood vessels is so fundamental in most of the all critical aspects of our life. You need blood vessels. But when the formation of blood vessels, now I'm coming to the point. So blood vessel formation, when we are talking, there will be, I told that sprouting blood vessel formation, then into susceptible blood vessel formation. Different kind of systems are there for the formation of blood vessels. But fundamentally, when it starts, I'm talking about fundamental cell biology. When the blood vessel is starting, formation is starting, then of course it is cellular activity. And the cellular activity makes such a way that the very first things I mentioned, that proliferation, migration, and communication to the outer world, all these phenomena work in such a way together that it forms the vessel. That means blood vessels will be forming from blood vessel cells. Those cells are called endothelium. You know that. Endothelium. Endothelium is the inner lining of the blood vessels. This looks very innocent kind of cellular layer, but it is most active and most important cellular layer. Last 30 to 40 years, we already observing it and it's already proven. These apparently look innocent cells are the most difficult cells and most targeted cells for any kind of clinical development and any kind of drug targets. These cells. So these cells are required to form the blood vessels. Now you think a fundamental point, structural point, not biological point, structural point. Blood vessel is a tube, long extended structure. Blood vessel is a tube-like structure, long extended structure. That's the very, very popular concept. The moment we tell blood vessels, then you think that it's a tube. And formation of the tubes, naturally you need cells. Formation of the tubes, you need cells, and those cells has to be come together to form the tube. And tube has one direction. For any tube, it can be glass tube, it can be plastic tube, it can be blood vessels, whatever it is. Once it's a tube, then it is a one single direction. Tube has a direction. Okay, it is not everywhere tube's direction. Direction has a one direction. So tube has a direction. Okay, highly structured direction. So when it comes to direction of a tube, then that is the formation of blood vessel, a tube getting extended, and there are lots of cells together. But there is a starting point, initiation point at the tip of the tube has to be there. You got my point. There has to be a tip of the vessel. There has to be a tip of the tube, because this is unidirectional one point progression. So there will be a tip. So now we are talking not only endothelial cells. Of course, endothelial cells are required to form the tube. Okay, that we agreed upon. It requires lots of endothelial cells comes together and they will form a tube. But tube has a direction, and that direction is unidirection, and that direction is only single point, very single point. So that single point, one cell will be there, only one, not two, only one cell will be there. That single cell is called the tip cells, leader cell. So this is very interesting and fundamental aspect. One single cell is giving directions to the tube. So if you see, now let us all consider this cartoon. You see the one toddler is indicating something and there is a toffee. and that fellow is after the toffee. So now this toddler is going to get that toffee, and toddler is scrolling, and that scrolling makes him extended. The scrolling makes him directions, and the toffee is giving him direction, and that direction is make him extended and scrolling, and he is getting other fellows behind him. Come with me, we will get the toffee. So this other fellow, the first fellow is the tip cell, leader cell, and the behind other fellows are there many following that fellow. They are called stalk cells. They are phalanx cells. They are following this fellow leader. So we are talking about single cell. That is called tip cells, and this is perspective is angiogenesis, blood vessel formation. So now if I try to just one second. Video is not working. Let us try this video. Now you see this video. This is a real time tracking of blood vessels, formation of blood vessels, and you see that the cells at the front is progressing. It's a real time recording. In a laboratory setup, you need to make these cells to be there, and then you have to induce them. And under the induction, there is a specific way to induce them. And under the induction, you will get the cells progressing, and you can follow the single cell. That was the video. So now for the next slide. Yeah. So So, to make it simpler now, or diagrammatic. So, in angiogenic affairs, what is happening? In angiogenesis, the process in which blood vessels sprouts grow out from a pre-existing vascular net cells guide the following stalk cells and sense their environment for guidance cues. তার মানে what it means that the angiogenesis, during the angiogenesis, when the blood vessels are getting formed, this one single fellow is progressing, and that fellow giving some signal the cells behind him, and those cells are according to those signals following and maintain their specific structure required at that point. The stellate cells, it needs a specific structure. At a cellular level, it's this cells size, if you consider, it is only 10 micron, 8 to 10 micron cells. So one cell is so powerful that it is going to give you the direction, and it will maintain its structure. You see the structure on the top, tip cell structure. It's like a branch, so many branching off, like trees branch, so many branching off. This is called extension of the cell. This is called philopodia. This philopodia number a lot. And then stalk cells, no philopodia, not even single extensions. You see, not the tip cell, single cell, the leader cell is giving lots of philopodia. It's flexing its muscles. It is trying to get communicate to each other. It's trying to communicating to outer world. It is flexing it, withdrawing it. Within seconds, you will see 10 philopodias are coming out, 20 philopodias are in. Sorry. So it's very fascinating to see in real time. So now, just behind stalk cells, you see, so quiet, slender structure, typical cellular structure, nucleus is there, it is dividing, and phalanx cells. Behind the stalk cells, phalanx cells, their structure you see, their structure trying to make a vessel-like structure. So in a dynamic system, when they are under some kind of cues or some kind of directions from the surrounding, for example, you just there's a picking of one thorn in your finger. There is open, little bit of blood oozing out, and that has to be repaired. And that has to be repaired means within after coagulation, after 5 to 6 to 7 minutes, blood oozing stopped. Still you can see spot of the red, and then there will be little bit of swelling, little bit of water deposition, little bit of edema, and finally you will see that your pain is getting reduced, and within 24 hours that red spots also gone and your finger is now getting clean. So in this process, during this process, starting from the very point zero, that is the picking of your finger, this angiogenesis process got started, and the very first leading role is getting by these tip cells, stalk cells, phalanx cells, and corpuscle cells. Okay, so now we are talking about endothelial tip cells. What kind of what kind of what kind of properties it has? It has philopodia, which is polarized structure. It can migrate much faster than other cells and limits tip cell number, recruits parasites. So at this point you note the limits tip cell number. What does it mean? That means when there is a teamwork, when there is a team, there should be one captain and one captain, not two. No team can perform better with two captains. So one captain. One captain has specific features, specific strategy, specific boldness, and specific functions. For any in cricket, in football, in angiogenesis, everywhere the same rule applies. One person. And then you think of the endothelial tip cells. There are lots of endothelial cells. They can take care of things. They can come and hijack this fellow, but it won't allow. So that is the limit tip cell number. Number is one, limited. It is not proliferating. It is not making two. You see, one. The behind stalk cells, they are proliferating. They are making two. Phalanx, they are making 3, 4, 5, 6, multiple cells to form the vessel. But tip cells maintains the number one. And that's a very specific signaling process is there to make the number one. So this specific cell has specific feature, specific molecular signaling, and specific structure. So when you are talking the signaling, what signaling we are talking around? So you think of a system, for example, this wound, you think of tumor, you think of embryo development. There is a microenvironment around the blood vessels. There are lots of blood vessels are getting formed, and in a strategic way. And in the strategic way, no, it is forming the blood vessels, these endothelial cells, tip cells, stalk cells. Then there will be a microenvironment around it. Okay, there is a it's not alone, it's working with the whole world. There is a micro environment, and that micro environment is mostly fluid in nature. And in this fluid nature, what is there in this, why you are calling micro environment? Micro environment is the basically whole universe. What does it mean, whole universe? Micro environment, you have electrolytes, you know, no need to mention what is electrolytes and what are the electrolytes. You have peptides, lots of active peptides, inactive peptides, broken peptides, semi-formed peptides, mature peptides, all kinds of small protein stretches. Those called peptides. And those peptides are of different kind. It can be. It can be immune peptides. It can be cytokines. It can be other immune molecules. It can be different other kind of inflammasomes molecule, and there can be growth factors, a battery of small molecules called small proteins, I would say, not molecule exactly, small proteins and peptides, small peptides. These peptides are growth factors. You know, there are popular growth factors and you should remember them like VGF, PDGF, FRGF, uh, all kinds of growth factors are there. There are small stretch of peptides. These peptides are very active metabolically, hormonally, metabolically. When it's molecular signaling, they have specific signaling. There are specific receptors, and these ligands, these peptides, these growth factors, these cytokines, they have the specific specific expression of their corresponding receptors on the philopodia of the tip cells. This is the cartoon it is showing. So better to get the concept. No need to memorize the name of the growth factors, but the concept is what? There are growth factors, there are immune molecules, there are cytokines, there are other kind of hormonal molecules, there are other kind of small like GSH, accident, antioxidants. All the things are there in the surrounding. That is the microenvironment where blood vessels are getting formed. Now, these tip cells has to be very specific. It cannot get everybody on board. Impossible. I need the people whom I need now. So, I will prepare my receptors. I will express. So, it's a cell. It has a nucleus. It's a RNA. It is the transcriptome, and it has the battery of mechanisms where it is getting formed after transcription, the formation of proteins or peptides. So only one cell, it is making everything to make it more specialized. So I need these 1, 2, 3, 4, 5. I need VGF3, I need VGF1, I need PDGF, I need FGF, 12. These 4. I want to express those receptor molecules on my surface. Because in microenvironment around me, everybody is there. I cannot get everybody on board. Like when you choose friends, there are lots of people in the world. How many are friends for me? I have chosen. So that means I expressed my knack and receptors for those kind of personalities who will be matching with me, my requirement, my psychological need when I'll be talking to them. We call this wavelength matching. In a similar way, the tip cells is getting expressing those specific receptors whom these tip cells need, not stock cells, not the cells below the tip cells phalanx. Only tip cells are making those. Stop cells has different kind of friends. Phalanx has different kind of friends, but tip cells have specific kind of friends. For example, here, just for example, it's put the VEGF receptor 3. That means this receptor is expressed. You need VEGF on board there. VEGF receptor 2. You need VEGF2 on this VEGF receptor to interact. You need enos expression, that's the protein producing nitric oxide, that will come a little bit later. Then NRP1, you see this for example for this thing, interaction. So ligands are red boxes and coming to receptor. The moment it is receptor ligand interaction, there will be a downstream signaling and the cells are going to behave in a specific way. That means it continue with leadership. To maintain the leadership, all these people are required. And when this work is done, vessels are significantly progressed and I should not increase the vessels further, then that moment these receptors are getting catabolized. These receptors are getting in the protein degradation pathway. Immediately, protein degraded receptors are gone, vanished, and the ligands are lying there but no work. These endothelial tip cells withdrawn from the system, blood vessel formation stop. So this is the more or less concept of the tip cells. Now you see that there is in a series we are showing that front one is tip cells, then stalk cells, then phalanx cells. Okay, so there is based on that there are different kind of receptors, and these receptors molecular structure, schematic structures are giving here. So TGF beta receptor for TGF beta in tip cells are getting expressed. TGF beta ligand is here, and so TGF beta molecular structure, if you like to know how it is getting produced, how it is going to get TGF beta on board, that means interactions with the ligand to receptors, then you have to go for further study and further research to understand it. On left side phalanx cells, you see that VEGF receptor 2 and VEGF-A, how they are interacting together, and finally downstream signaling, and downstream signalings are mostly through kinases, downstream signaling to them. Some of the kinases are already there at the first place, that means as receptor. But some kinases are coming downstream to those receptors. So kinases, how many kinases we have is very important for you students to know. How many kinases we have in human? We have close to 500 kinases. It's little more, but whatever. Round figure 500 kinases we have. What kinases does? Kinases are specific kind of protein and enzyme which causes addition or breaking of some energy molecule, for example, phosphorylation. That's the kinase. Then the other kind of kinases are there. So those kinases causing the post-translational modification of the proteins. These post-translation modification, for example, phosphorylation. Once the one protein get phosphorylated, it can be activated or it can be inactivated as well, based on where it is getting phosphorylated. So this process is done by kinases. So kinases are, irrespective of anything, kinases are extremely important for us, health and disease both. So this is why there are kinases are very popular target for present days cancer biology, cancer drugs, very popular target. So downstream to this signaling are most of the time kinases. Okay, so now the tip cell will have different, a battery of kinases and battery of growth factors to be acting on it. Then it will suppress stock cells to become tip cells. See the interesting phenomenon. I am the leader. You should not be the leader. The next one. So I am going to produce some signal, some molecules, and that molecule is I am going to send to you, and you will become docile. No ambition for become tip cell. Stock cells is stock cells. For next 20 minutes, I'll be the tip cells. Next 2 minutes, I'll be the tip cells. You will be just following me and do your work. Don't try to be another tip cell. So tip cells is going to create that signaling. I will maintain my structure, function, and the specific structure like a tree-like branches. You see, others are not. So these branches I'm going to make it, and you should be like a trunk, no branches, nothing, and you follow. So this is the tip cell. This is the concept of then tip cell. Okay. Now we have to work with tip cell. Now we have to work with tip cell. Now you can imagine 10 micron cells. There will be thousands of cells, thousands and millions of endothelial cells around. One cell is going to be tip cell, and you have to follow it, and you have to document it, you have to image it, you have to do transcriptomics of it, you have to get nucleus out of it, you have to image it, and you have to define it as tip cells. So you see the challenges when it comes to experimental research. Till now what we are talking, the story. Okay, a nice story of what is tip cells, what is this cells, that cells, all kind of things. Tip cells is working this way, that way, fine. But now we have to work with it. And just to put one another point, metabolic pathways in angiogenesis. If you see the metabolic pathways in angiogenesis, when it comes to tip cells, then your metabolism of the tip cell is very unique. Even in a single cell, metabolism is unique. Okay. now Now we have the tip cells. How we do get tip cells? We grow endothelial cells. For example, we get endothelial cells mostly from human umbilical cord, or from bovine aorta, or from few other animals also you can get endothelial cells. These endothelial cells you grow on the plate. When you grow on the plate, you have to tell world this is the tip cell. This is different than other endothelial cells. So we induce the system to become some cells becoming tip cells. Fine. Now how will prove it is tip cells? Though there are some biomarkers. Whenever you are doing any experimental biology, cell biology, then you have to prove it with biomarkers. So one biomarker is endocan. Endocan is a specific protein expressed in tip cells. So what is going on here? Here we have one single tip cells. You know, one single tip cells. This is single tip cells. We used fluorescence technique, antibody technique, to detect endothelial nitric oxide synthase, one of the markers for the tip cells. and we find there are red spots on the tip cells. Here is the nucleus. You can get impression of the nucleus, you can get it here. It is a shaded area. Rest of the things are fuzzy red, and some spots are specific red spots. So when we treated the cell with antibodies against endothelial nitric oxide synthase, then specific spots we find on the cells, not everywhere, some cells at the end of the cells. It's like a cat's claw. Cat's claw. If you see cat's claw like some areas where very dense endothelial nitric oxide synthase proteins are there. So this is red spots are nitric oxide synthase. The same cells, we use second antibody, which is give you green signal. Okay, GFP, green fluorescent protein, GFP signal with antibodies. This target is endocan, another protein, which is expressed in T cells. So now when we first we are going to give proof that endocan is expressed in these cells, then there is a big chance that this cell is T cells. Confirmation. Then we find enos is also expressed in these tip cells, right? Endocan and enos, how they are far from each other or they are very close. When we merge this image red and image green together, it's a merged third image is merged image, and the nucleus is here blue. There is a specific dye used for the nucleus. It's blue, and now when it is merged, you see that endocan, the protein endocan expression site location of endocan and location of endothelial nitric oxide synthase on the tip cells in a similar place. That means possibly they are working in a similar and critical job for the tip cell tipness. To make the tipness, we use this marker, and so it's proving the endothelial cells, which is tip cells. It's the proof for the tip cells. At the same time, it's the proof for nitric oxide synthase and endocrine. They are coming together inside the tip cells to do some job for the tip cells. Okay, so there it's a published work long time. So there are some signaling. I told you that this VEGF signaling, how it is going to VEGF. There is a tip cell in tip cell. You see, don't go into very critical and very difficult slides like this. Better to make it this concept simpler. The upper one is, you can see it is written tip cell, upper one. Then we are talking about the stalk cells. So I already mentioned you, tip cell has specific kind of signaling process. Stock cells has different kind of signaling process. Instead of going into very critical analysis of this process and all the explanation, better to make it simpler, and I will tell you there is a notch signaling. It is called notch. Like VEGF, I told, vascular endothelial growth factor. There is a called another ligand is called notch, and this notch signal is very fundamental to our development, to cancer, to our wound healing. Notch is very important. So this notch signaling, when you are coming to just during tip cells things, then you see that tip cells has the low level of notch activity. So what does it mean? If notch activity is more in tip cells, then all these phylopodias will be withdrawn. Tip cell doesn't need it. Tip cells, what it is doing, they are getting VEGF and VEGF receptor interaction, and then downstream producing some molecules which is going to go inside the stalk cells. It is not keeping, it is a cargo, and it is giving expel it out to other cells. It is not keeping itself, and that particular notch signaling making the stalk cells quiet. Stalk cell doesn't have the ambition for getting into tip. So stalk cells, not the stalk cells are now less ambitious. So and notch activity is high. So very crude concept, but very important concept. Tip cells, notch activity is low. Stalk cells, notch activity is high. How it is making one single 10 micron cells, which can be seen only under microscope and so difficult to follow that one single cell, how it is doing? This is called signal transduction. I will start a signal transduction in my place, that's the tip cell, which will produce some molecule. Those molecules I am not going to keep myself, I will be just handing over to the next cell, that is the stalk cells, and that molecule active in the top cells, and that activity, notch activity is high, so it doesn't make the ambition for the becoming tip cell, it becoming stalk cells, phalanx cells. Because somebody has to make the blood vessel. It cannot be active like tip cells everywhere. So that is the game of tip cell signaling. Just last point, very brief. I will just go. How, for example, how we're all talking of, again, still it is like a story, but how we are going to make it? One is that endothelial cells. I told you that you get the endothelial cells. It's a long process. Okay? It takes weeks to months to make whole thing. So you take the endothelial cells from the umbilical cord of the human being. From the umbilical cord, you go into the endothelial cells layer, get the endothelial cells out, then grow them in the laboratory. Passage 1, passage 2, passage 3. That means you are going for the extension of the cells. These are called primary cells, not immortalized cells. They are primary cells. These are primary cells, and there will be some kind of cells will be immortalized, easy to use. You don't need to get it from the tumor, or you don't need to get it from the tissue like placenta. It is just going for years after years after years in laboratory. That is immortalized cell line. But here we are talking about cells. So here we are getting the cells from the human being or from other sources, we will see. So here you see, here here instead of human we have placenta assay. Here what we are doing, here where we are doing the embryo. Which embryo? With the chicken embryo. The chicken embryo is, there is an age is 29, age is 35, age is 37, it grows. So scale is 1 centimeter. You can see the size, you can imagine that how big it is. So from this embryo at one particular stage, 12th day, we are getting this embryo and we are getting the aorta. You know what is aorta. We are getting the aorta. We are getting the aorta and heart, and then finally we are getting aorta. With these indications and arrow, it is shown in the plate. And this arrow is going to, so this is the egg, embryo is out, you are getting the heart, you are going to take the aorta, and you are going to take the small piece of aorta less than 1 millimeter, small piece of aorta you are keeping on a system, it is called matrigel, which gives support to any life system tissue to survive. So on this matrigel, and then we are keeping in the incubator. It's called CO2 incubator. 5% CO2 is always there for maintenance of the pH and 37-degree temperature. It is keeping there, and you are following days after days for this aorta. And this is the small piece of aorta you are going to keep on the, and then I'm not going into. So this is the history of the aorta, that there you have to prove. No, people will ask you, you took the aorta from the embryo, possibly there is no endothelial cells, there is no vascular system, so you have to prove that the vascular system is there with specific dry and history. And then you have to go for example, any this one, let us consider. You see, so here 24 hours, 48 hours, 72 hours, we are following. 72 hours, no sprouting. 48 hours, sprouting. 72 hours, huge sprouting. That means when you are inducing, then blood vessels getting formed from these blood vessels, small pieces of the blood vessels. And you see that how many blood vessels are coming out from the, so these are all, and you find that tip cells here. So with proper microscopy and high resolution microscopy, you are going to follow the tip cell here, lifetime, life tip cells, and you are going to get it here from this. And then with different kind of stain, dye, and all the things. Here we used phalloidin. Phalloidin is the actin polymerization dye that defines the cells. So here find the cell structure, forming pattern, tip cells formation. Here you can see. Here you can see that there are several cells are there. These cells are coming out from the aorta, and easily you can see tip cells here. Here is one tip cell, here one tip cell. You follow it as a tip cell, you work on it as a tip cell. So all kinds of sophisticated work you can do with these tip cells. You can, with laser capture, you can take one cell out and you can study them. All kinds of things you can do. So I think we don't have much time. I already crossed the time. So here you can see the from human placenta. The placenta, small piece of placenta, very small piece, like chick aorta. are given there, and day 1, day 3 till day 21 we are following. In case of chick embryo, it is much faster forming the blood vessels, but when human placenta, it is not that fast for many reasons, because human is higher, animal structure is higher, signaling is more complicated. It's very difficult to process the for 21 days to keep the piece of the placenta, and still we find that 21 days sprouting started coming. Basically, on day 12 itself is started, and then gradually it's very visible at 21 days. You can use this model also to do this thing. And maybe one slide I can show you. So here I just tell one thing regarding thalidomide. Thalidomide is a very dangerous teratogen, means it causes malformed babies. At the same time, thalidomide returned back as absolute drug. 1998 it got returned back. 1960 it got banned as teratogen, and 1998 it got returned back as a leprosy, a specific kind of leprosy. It's the absolute drug. And 2006 it got approved second time is for a major condition, very major condition, that is multiple myeloma. So this is thalidomide. You, as a medical student, you know, I think thalidomide, and you should know in detail about thalidomide. When these thalidomides are this the leprosy, and it got cured within 6 weeks. In 1998 it got approved by FDA, this thalidomide, and now there are analogs also. Now this thalidomide works through the blood vessel formation. So now we started the thalidomide work, thalidomide effect on the tip cell formation. When this tip cell formation, if you see, the first one is control, the second one is another control with nitric oxide, it is inducing blood vessel formation. Then we use thalidomide. Then you see there is a drop from the, if you compare from the control to thalidomide treatment, there is a significant drop of number of tip cells in thalidomide treated experiment. Then there is lenalidomide, there is another thalidomide analog, then pomalidomide, there is another thalidomide analog. You see, in all cases, it's suppressing the tip cells. So tip cells getting suppressed specifically with thalidomide and its analog. Now, just one experiment. This is very, I would say, very challenging experiment. You have to follow the cells in real time, and real time videography you need to do. What we did, time lapse imaging of the endothelial tip cells. Okay. Image quality is not very high, and you need very big screen to really see it, but still the whole concept is 0 to 40 minutes, 0 to 40 minutes, 40 minutes, less than 1 hour. We are following the cells, videography is going on. And when there is a control, that means we kept the cells as it is. We are not treating them with anything. Then the cells are coming together, migration. At the very first slide I told, migration, proliferation are very critical, and crosstalk. So what cells are doing? They are migrating, they are touching each other, and they are trying to form a tube-like structure. That's the control. That's the blood vessel. When thalidomide is given, it is only cells are there. No crosstalk, no tube-like structure. Lenalidomide, only slender structure. Pomalidomide, slender structure. And that makes you prove that thalidomide and its analog inhibiting tip cells formation. So now, break and make. Our proposal is that nitric oxide signaling, nitric oxide is a cardiovascular very important molecule. It causes relaxation of the blood vessels, it causes relief from the hypertension. Every second, every moment it is working in our cardiovascular system, and there are several drugs based on nitric oxide release in market. So this nitric oxide, we propose that this nitric oxide helping forming tip cell formation and blood vessel formation, pro-angiogenesis, supporting angiogenesis. So what we find, thalidomide breaking angiogenesis, and nitric oxide you are telling making angiogenesis. Break and make. We did one experiment. What is that experiment? So this is Bit difficult, but still try to understand. 0 to 40 minutes we are giving. Image quality is very faint here. I can see in my laptop, but possibly you cannot see it. So okay, here this one is bit better. Okay, so here one analog is given 0 to 40 minutes. There is a ring structure. 3 endothelial cells migrated and came together to form blood vessels. That's the whole concept. 0 to 40 minutes, it is consolidating that concept. It is coming together, forming a ring, forming a blood vessel. At the 40th minute, when it is forming a ring, meaningful ring, just before that, just when it is forming the complete ring, just before that, uh, so when it is other way, so it is forming a ring. We used lenalidomide, which is the analog of thalidomide. It inhibits blood vessel formation. A complete ring was there at time 0, and then we added lenalidomide, and we are just getting opening the ring. That means it is inhibiting. Yet no, don't form it, don't form the blood vessels. I'm inhibiting tip cells. It is opening up the ring, breaking the ring. The moment it is breaking the ring at the 40th minutes, at that particular moment we are giving nitric oxide to the system. That means we are bringing the system in the brink of breaking and giving nitric oxide. Let us see what happens. Surprisingly and very interestingly, what's happening? This nitric oxide, which is coming from a spermine nonoate, one donor, it releases nitric oxide. So the moment nitric oxide is given, within 10, 20, 30 minutes, the ring is coming back. The ring which was going to open with the lenalidomide already opened. The under nitric oxide, under nitric oxide, it is making. That means this shows that the tip cells are sensitive to lenalidomide-like structure like thalidomide, which is negative force for it. It stops formation of the blood vessels, and when we are giving nitric oxide to the system, one specific signaling molecule, then it is stopped that breaking. It's making renewal of the blood vessels, renewal of the formation of the blood vessel process, and that is the ring formation. So with this, so thalidomide and the analog affect morphology and cellular shape of the tip cells, and nitric oxide can really protect the cells and induce the blood vessel formation via sensitizing the tip cells. That's the concept, and later I'm not going. So this is my team. It's a old team. Now I have a very small team. That time it was a big team, and many of them worked in this process. And I think I'm sorry for the time I took very long. And this is thank you. And here you can see nice image of these tip cells and stalk cells from our work. This tip cell is giving here the tip cells and the stalk cells, and it is different kind of dyes and fluorescent probe. It is. Thank you.
Yeah, thank you so much, sir. Over to Dr. Tirupati, sir, to say.
Thank you very much, sir. Saurav, sir. You have given tips on tip cells. How the signaling pathways are working. It's a really wonderful presentation. We enjoyed your presentation. We could travel into the cell and see the molecular actions and all. So the physiology has traveled inside the molecular biology. And
Cellular
thank
physiology.
you,
You are
you
very
people,
right.
the biotechnology people are magnifying the functions of the cells and all. I think it will be very useful for the scholars who are taking up the research work in the cellular biology. Thank you very much, sir. Thank you very much.
Thank you.
Yes, over to Dr. Gopinath.
Yes, sir. As we draw this session to close, it's both an honor and a privilege to acknowledge the chairperson and on behalf of organizing committee of BMSCon, I warmly invite Dr. Suraj Chatterjee to accept a token of appreciation as a form of e-certificate and also an e-memento.
Thank you very much.
Thank you for joining us, sir. Now I have the pleasure of inviting our chairperson, Dr. C. Tirupati, sir, for having chairing this session in a very nice way. Thank you, sir. As a token of
Thank you for your,
appreciation, a e-certificate and e-memento, sir.
thank you.
Thank you, delegates. We are a little 10 minutes late. So can we have 5 minutes stretch break? And we'll resume back at in 5 minutes, 11:38 now. We'll back be 5 minutes.
Okay. Thank you.
Thank you, sir.
Bye.
Thank you, sir. Kindly reassemble after 5 minutes for the next session.
Good morning, Sucheta ma'am. Ma'am.
Good morning, madam.
Welcome back. We now continue with our next session on topic Translation of Healthcare by Liquid Biopsy from Labs to Clinics. I invite our moderator, Dr. Gautam Sarkar sir, Professor, Department of Biochemistry, Avmc, to kindly take over the session. Over to you, sir.
Before Sir speaks, Dr. Sucheta ma'am and Professor Dr. Afu, I'm extremely happy that you have accepted our invitation and you are here. Thank you so much, ma'am. Over to you, sir.
I have the proud privilege of introducing Dr. Sucheta Kumari. And am I audible?
Yes, yes.
Oh, okay. Dr. Sucheta Kumari is a director, Research and Development, Srinivas Institute of Medical Science and Research Center, Srinivas University, Karnataka. She has 40 plus years of teaching and 34 years of research experience. Research and academic contributions. She has 600 plus publications, H index of 55 plus, citations 14,559. One is index and 267. Okay, fine enough. And principal investigator in 30 plus funded projects from NIH, ICMR, BRNS, DRDO, Indo-Japan collaborations, and so on and so forth. She has guided over 28 plus PhD scholars, mentored numerous UG, PG students. Her advanced training and certifications include proteomics and fatty acid analysis from USA, ISO 15189 2012 training in medical laboratory quality systems. Her research focus includes cancer biology, molecular genetics and cytogenetics, radiation biology and radioprotective compounds, nutrigenomics, lipidomics, and natural bioactive compounds, cellular mechanisms of cytotoxicity and genotoxicity, neurobiology, and memory research. I think I should stop here as far as research focus is concerned. Then her honors and recognition includes Lifetime Achievement Award twice, Best Researcher and Women Researcher Awards in, how do you pronounce it, Nitri University, Most Cited Paper and National Scientific Awards, Dr. P.P. Jacob Award for the Best Scientific Paper. Over to you, madam, for introducing the speaker.
Thank you, sir. Thank you.
Thank you, madam.
So I welcome our Professor Dr. Afu Roring, madam. Madam, I'm very glad to see you in our this session. It is we are welcoming on behalf of Vinayaka Mission Research Foundation and on behalf of India. We are honored to have you with us. So, madam has done her MD and PhD in Public Health Genetics. I just came to know through some of my friends, and after meeting her, I really understood how intelligent and how focused on every subject, and she can touch each and every research subjects. So she had the physician come scientist experience for more than 25 years. And she's expertise in clinical medicine, public health genetics, mainly pioneer in food as medicine, liquid biopsy for regeneration and longevity. Core area of expertise, liquid biopsy, minimally invasive diagnostics, regenerative approaches in longevity, science, nutrition-based therapeutic intervention, precision medicine through genomic integration, ensure her legacy as a leader in medical innovation and patient care. Madam, we welcome you. A notable publication. She has got many publications. All of us can involve in her, along with her to give more support to our research also. Innovations in cardiovascular therapeutics, holistic approach to chronic disease management, the role of artificial intelligence in diagnostic medicine, pioneering research in neurodegenerative disorder, patient engagement and digital health technology, research input, advancing early detection through non-invasive diagnostics, integrating nutrition, genetics, and precision medicine, translating research into preventive healthcare strategies, bridging clinical practice with emerging technologies. Madam, today's topic is very touching, I hope it is very informative. Thank you very much for joining us with this conference. Over to you, madam.
Professor Sucheta, I'm so happy to see you early morning.
Thank you, madam.
It's cold here, it's 5 degrees, and it's an early morning, German morning. I have sent Dr. Manju my recorded presentation, and the next 43 minutes she will put in because I was supposed to be somewhere else, but I'm here as the recorded presentation goes on. And I'm very, very thankful to Professor Sucheta to introducing me to Dr. Manju and also connecting me here because like minds connect with each other. This presentation is basically what I have gone through myself as the only survivor of gene therapy, and I want to translate me. I was an experimental animal on myself. I want to translate this findings and observations I survived. So now I want to translate it further. So that's my main intention of this presentation. Dr. Manju, you can start my presentation. I'm here.
Sure, ma'am. Please start.
Hello to all of you. Firstly, I would like to thank Dr. Manju to giving me an opportunity to share my insights, how we can translate the healthcare by liquid biopsy from lab to the clinics. As we know, this year the World Health Day says like health from science, health for all from science. So for me, it was a concept like how can you translate the healthcare? Like we are having so many researchers in the labs. A lot of researchers are coming out. There are so many videos coming up on the Instagram, so many videos coming up everywhere. And we don't know what actually is happening in the clinic. The clinics in India are full, the practices are full. So you hardly there will be 15 minutes, the maximum limit in a clinic, the doctor is seeing the patient. But if you can focus and if we can go ahead and if we can start to get an opportunity, that would be something where we can bridge the gap between the two components. And today's presentation, 45 minutes, I know it's too difficult to hold the audience, especially online. 45 minutes, I try to make it crisp and nice. And I also shared with Dr. Manju that the time of my presentation, I have something which is very, very important. And it just came up last days and I couldn't say no for it. So as you're viewing my video presentation, I'll be there and I will join immediately whenever it is needed. In the conference or whatever is happening for answering my questions, or also at the end there's a scan code. You can write to me, you can write an email to me, and you can also connect to me through the website and other places, and I would be very, very happy to guide you further. So thank you very much for giving me an opportunity for the entire team, and I would like to congratulate all of you giving your time and passion in bringing a topic like this in the forefront. And I would love to do this kind of sessions in person, because in persons I like to see the smiles of the people. They are happy, and something I like. That's what I like. So why did I choose something translation of healthcare? Because I am myself is a beneficiary of that. So you can see now as I'm talking in the video, and you can see me right now. My little hair is grown. This was about a month ago, and that was me about 8 years ago in 2018. 6, 7, 8, 8 years ago in 2018. This is in Basel. You can see the clock of the Basel in Switzerland. I had a meeting with Professor Flammer, And this is how I looked: 150 kilos, disoriented, confused, lost, depressed, no hair at all, falling off hair. And it was too much of the body was producing corticosteroids. And I would like to say that I am one of the survivors of cancer for 17 years. It's a rare cancer. Finally, we found it in the lab where we can prove it's not a transform. And also, the most important is what I took it for myself. Like, this is a transition, it's not a miracle. There is a space, there is how it is. So everybody, when they see me, they ask, oh, did you take cosmetics? Did you take gym? Did you take Ozempic? How did you reduce weight? In 2 minutes, I cannot tell the journey of my everything. I can just show the next slide. This is one of the breakfast which I have here. Okay, basically, because I'm from Bangalore, I love the South Indian food. So this is I ferment, dosa. All of us eat dosa. This was one of the staple food in the 8 years ago. I used to make the batter. Then I used to mix the herbs, like fresh herbs, picking up because it was easily available for me. And I used to pick up, and then so you see the chutney and everything, and also eating the dosa with the fork, and the knife was also very interesting for the people around here. So I'm not saying eating dosa every day will reduce weight, but these were the herbs after the liquid biopsy, which we have fixed it through a complete module. I needed these herbs every day to reduce the production of corticosteroids and increase the production of serotonin in my body. So how does it happen? How did it happen? So we use liquid biopsy here, and with the promising of the liquid biopsy, ascertain what are the mutations in the genomes and what is happening in the genomes and how it can be done, and fix a meal plan and say how much to eat, how to eat, when to eat, and clearly fix the biological clock. So that's how it is. On my back, you can see the 2 mementos given to us from Srinivasa Medical University last month. They also conferred professor in practice for longevity, phytomedicine, and genetics. So now I'm a professor of longevity because it's something like that. So this is what one of the thing. It seems to be simple, and it's like people get complicated adding the business model. So let me go through what actually the promise is. So, the promise of the liquid biopsy in modern medicine, redefining precision medicine across multiple disciplines. For me, first is all of you. Every person has an intolerance, acquired or inherited. And when we do a liquid biopsy, we can see the TP53, what is mutated, and we can inhibit the mutation and reverse the mutations only by having the right food and right time you eat. The timing matters, the way you eat matters, the type you eat matters, and what is needed. You can't eat something with so many videos coming on all the networking sites. They just put everything and they say this smoothie will bring down. There are so many. The moment you search obesity, you will have hundreds of videos coming. But this is not that. Everybody needs it. You don't have to go and stretch yourself in gym. You just need to take what you need. It's just not, I cannot bring a coconut tree and I cannot plant it in Germany. The same way, I cannot bring the apple tree from here and plant it in Pondicherry or Bangalore or wherever it is. Every place is designed for every person. And this is where, even before it comes on the surface, we look at it. So what is liquid biopsy? The cell-free DNA, circulating tumor DNA fragments released into the bloodstream, enabling detection of genetic mutations and tumor-specific alterations for early diagnosis and monitoring. So what we say, a stitch in time saves 9, correct? So if you are able to identify what is it, I would like all of you here to get yourself a liquid biopsy done. I know it's too difficult in India, and allergic tests. So we have made a gateway from Bangalore to Germany, and it's there. You cannot change your genes. It's a one-time investment. I'm asking everybody. It's a one-time investment. For a kindergarten child, you pay from 50,000 to 5 lakhs, just a donation. Securing the future of the child. But if the child is not healthy, we don't know what the exomes are in the child. And the exomes, extracellular vesicle carrying proteins, RNA and DNA from parent cells, these provide rich molecular information about the disease state and the cellular communication pathways. So we have the cellular communication pathways. If the child, it has certain cellular communicating pathways where it is defected or something like that, it becomes difficult, right? So we cannot ask an elephant to climb a tree. If a child has a certain cellular communication pathway, we cannot ask this child to do another one. Circulating tumor cells, for example, because of the stress, there may be some intact cancer cells shed from tumors into the circulating tumor cells. This is for the cancer patients. So this is how you can think about it. So this is what I say, that exomes, core biomarkers and thing. Translation pathway from lab to clinic. So how do we do it? Translation. First is discovery, molecular signature identification through sequencing technologies and bioinformatics analysis, identifying novel barriers and discovering the exomes in clinical potential. Then analytical validation, establishing an assay reproductivity, sensitivity, and specificity across laboratory settings. Rigorous testing ensures enables detection. Clinical validation. You have this lab tests here and you have the clinical. When you join both together, then it works. You just have only this, it's just only one hand. Then you have only this, it's only one. But when you have both clinical and the laboratory, they both have to come together, to make a handshake together. This becomes a strong one. So this is how it is. So let me tell you how about the clinical implications. For example, cardiology. Early detection can help in EGFR mutation tracking. In oncology. Cardiology, you can find the sensitive biomarkers for myocardial injury detection, enabling non-invasive cardiac damage assessment and monitoring. Infectious diseases, circulating pathogen DNAs. You can get that. Then you have the main challenge in India is regulatory and ethical considerations. So here in India, because there are already so many of the devices and the machines laid in India, to get a new one, there are new approvals. In Europe, it is European Medicines Agency. Then you have FDA in US, PMDA, and BfArM in Germany. So here the regulations are working on predictive diagnosis, and they will give you an immediate regulation within a span of 18 to 26 months because it's on predictive and preventive healthcare. So challenges in clinical translation, technical and operational hurdles in low biomarkers, abundance requiring ultra-sensitive detection methods, pre-analytical variability in sample collection, processing and storage, lack of assay standardization across laboratories worldwide, need for advanced bioinformatics structures and trained personnel. This is like all the four are the barriers if we have to start somewhere. So then getting a digital health and AI accelerating translation. So you do have a lot of clinical data in India. Getting a digital health added to a liquid biopsy and transferring, that is AI and machine learning algorithms. For example, now I'm just creating a machine learning with the samples of placenta, the images of the placenta. Then we have the intolerance tests, like what is happening. So I'm combining the intolerance tests and the images of the placenta and the liquid biopsy to ascertain the preventive health care of the mother and also of the child. We can directly mark it out. So this is where the collaborative initiative is in process. That Blood Pack Consortium, that's US, European Liquid Biopsy Consortium, and private-public partnerships. In India, there are private-public partnerships. So I'm looking forward how we can collaborate. Like you have the technology here in Germany and how we can bring it down to India. We are designing a microscope where Abdul Majid Kamran, who is the CEO, and also my son, he wants to get a digital electronic microscope where it can be carried at a cost of just $50, $50 to €5. It is a portable one where there can be a drop of the blood, and then you can take it, drop of the blood, and you can take it across further, and then you can design the nutrition deficiencies and everything. So this gives a pointer if we need a liquid biopsy. So that's how I want to collaborate in this. I'm open for collaboration, students, because getting revolutionizing cancer monitoring. The role of, that's what Dr. Christopher, that's my German husband, and he's also honorary technical director for this. So during the palliative challenges, especially the cancer patients, they are just waiting. They think they will all die if they are stage 3, stage 4. I was in stage 3 and I'm still here. So from palliative care to personalized medicine. So this gives a very good monitoring cancer progression in palliative patients for optimizing the treatment decisions and maintaining. We don't have to give the cancer patient what they are not adaptable. So we can check right in the liquid biopsy connected to the intolerances acquired and inherited intolerances they have, and then bring it together, and then we can do a tailor-made personalized diet. So limitation of traditional biopsies. Surgical biopsies cause significant discomfort and not feasible for frequent monitoring in fragile palliative patients, delays in detecting the treatment resistance and tumor evolution. So this one, when you get a liquid biopsy and an intolerance test, this one will reduce the time of trial and error of the medication the person is getting. So revolutionizing the approach is just finding out the technology provides, how we can bring it together, how we can revolutionize it together, and how we can combine it together. So like the key concepts is cancer progression and non-invasive monitoring. You don't need to keep on taking the blood sample. I knew that one of the patient, when I sent somebody to pick up the blood for the liquid biopsy, she was not ready to give the blood because every 2 days they were taking the blood and they were monitoring for a CKD patient. So every 2 days, here you have only one time. You don't have to, you don't know how long does it take. But personalized treatment adjustments, yes, everybody, you can give chemotherapy, but every person has a different food and the diet incorporation. Every person needs different food at different times and different methods. So it's not just like we take one, we don't take the other one. So all this together, liquid biopsy transformation, clinical utility in palliative care settings. So how do we get the liquid biopsy? Yes, we can create a lab for the Pondicherry College with Dr. Manju there. We can start to work on it. And how do we work on it? To understand initially what is needed in and around Pondicherry, what are the patient's inclination. So every place, we cannot just make a machine here and do a biomarker there. So we have to go with one after the other. Na? So that's how it is. So non-invasive, free monitoring process, frequent assessments, improving quality of life, supports dynamic personalized treatment plans. So personalized plans, supporting dynamic personalized plans is the biggest advantage of this. So healthcare systems advantages, cost reduction. If they know that as a cost reduction through precision medicine, then optimized treatment strategies, reduced surgical procedure demand, elimination of ineffective therapies. So this is the biggest one. How we can do is we can reduce the cost. We don't have to burden. There are 15 to 20 medicines on a slip. For example, a woman between 25 and 30, she's also already a mother, she doesn't have to go for a hysterectomy, correct? So when we check and we put a precision medicine to her, optimized treatment strategies, so continue we like monitoring the optimization of that, and reduce surgical procedure demands. Laparoscopic, okay, you want to take out the fibroid, only this. But if we can able to dissolve this by intravenous procedures, by giving them what is needed intravenous, by putting them on the diet, by optimizing their regular use, so we can reduce the surgical demands and elimination of enough. We don't have to give simple metformin. There are many people who are intolerant to metformin, but still they keep on taking, and because they have a diarrhea, they have a stomach upset, they take another medication. So here, if it is ineffective, then we can stop. So early detection treatment allows rapid therapy modifications, preventing continued investment in drugs that no longer benefit the patient, and redirecting resources appropriately. So here, research evidence and case highlights, detection of resistant mutations, clinical implication progress. So this is going on, analysis, tracking, detecting the resistant mutations. So one favorite topic is for me with polycystic ovarian syndrome, and this is where I would really love to collaborate. South India, even though we have herbs right now, I see that out of 10 girls, at least 4 girls at the age between 10 to 15 are with polycystic ovarian syndrome. And furthermore, they go on with polycystic for ovarian fibroids and myomas, and they go in for the surgeries, and if they see the big ones, they take it out. So if we go on polycystic ovarian syndrome, the most common endocrine disorder affecting the women of reproductive age, characterized by hormonal imbalance, irregular menstruation, and ovarian cysts, studies indicate that PCOS affects approximately 6 to 12% of women globally, with a signature proportion being adolescent females. Among the adolescent females, PCOS prevalence ranges from 8 to 26, making it a critical health concern during the formative years, especially between 25 to 30. And then the condition not only impacts the reproductive health but also increases risks of metabolic syndrome, type 2 diabetes, cardiovascular diseases, and psychological disorders, including anxiety and depression. I have seen many of them going through those who were diagnosed with PCOD or PCOS automatically fall into a category of type 2 diabetes. Furthermore, the psychological mood swings, anxiety, and depression. Early diagnosis and proactive management are essential for mitigating long-term complications. Timely interventions can significantly improve the quality of life, preserve fertility, and reduce the burden of associated comorbidities. Understanding PCOS is the first step towards the effective care. So, understanding these comorbidities, the challenge of early detection. Key diagnostic challenge. Over 50% of PCOS cases remain undiagnosed during adolescence, leaving countless young women without the care and support they need during the critical development. See, they don't go. They just say, oh, I have pain during menstruation, I have pain before menstruation, but we don't know what it is. The diagnostic gap stems from the symptom variability, limited awareness among the healthcare providers, and absence of standardized screening protocols for adolescent populations. Early detection is essential for preventing long-term metabolic, reproductive, and psychological complications associated with untreated PCOS. This is where I really want to interfere. I want to collaborate, because the liquid biopsy means about 2 ml of blood or about 1 ml of the serum, we can identify there is a PCOS or PCOD concern and how much the mutation has happened. So in this way, what will happen is, and also connecting it with the intolerances, acquired or inherited, both together can give us a predictive diagnosis of PCOD and the hormonal deficiencies in the body, and then we can bring it down. We can bring it into a labs. We don't need a laboratory biopsy. We don't need to do a biopsy to identify. Even the intravaginal scans for a girl of 10 to 15 years is not allowed, That's where I come in. So this is where I want to bring in heterogeneous symptoms, like the symptoms, a clinical side, the symptoms, and limited imaging accuracy. So identifying a limited imaging, then treatment variability. If we can even check the intolerances and put the girl on the anti-inflammatory diets and prepare a plan, then it is like, you prepare a plan, you have a liquid biopsy, you prepare a plan. It's like you're securing the future of this girl. She will not be obese, there will be less acne, her hair will not fall. So she's not going for multiple variants where, like hair fall, you have something, you have obesity, something. Here we can exactly check what is the reason for her hormonal imbalance, what is leading to PCOD or PCOS, and what is the intolerance she has. And liquid biopsy, which gene has mutated, would be like we have BRCA1 and BRCA2, but we forget TP53 and many other genes responsible for the hormone balance. When we check this together, bring it on a meal plan, put it on together, automatically the weight will reduce. You don't have to go to the gym, take the herbal, compensating, no, not like immediately cutting the sugars, not like immediately cutting the carbohydrates. We can just say that sugars are needed, but which one? Fruits, they don't take fruits. They say sugar. We used to love to eat. Is it the fruits or the sugar which is intolerant or what it is. So transforming innovations, transferring PCOS care, advanced treatment and technology. So this is the one which we are right now working on developing. Advanced image technology, where robotic microscopy represents a breakthrough in the clinical imaging, offering unprecedented precision in visualization of ovarian structures. This advanced technology enables clinicians to detect these subtle morphological changes in the ovarian tissue with an exceptional clarity and consistency. By eliminating the operator variability and enhancing the image resolution, robotic microscopy provides reliable reproducible results that support early detection of PCOS related to ovarian changes, facilitating timely intervention and improved patient outcomes. So high resolution, now everybody has, you can just connect this microscope to your phone, record it and do it. Advantages of robotic microscopy: precise follicle visualization, reduced operator dependency, enhanced reproducibility, AI integrated potential. So the AI what we have developed in the whole thing, about 76,000 samples from Bangalore to Mysore in India and all others. So how do we bring, and what is the system? The clinical data. How do we combine the diagnostics, demonstrative, in vast analysis, like you have 10-15 minutes every school, the schools like high schools, the girls come out with acne, some they are not eating, so they are not having enough of energy in the brain, they're not able to monitor and see how it is. So we can go up to the schools. It will just cost 25,000 rupees for the intolerances, just a 2 ml of the blood under the guidance of the parents. If they're investing thousands on their private tuitions for a good education to settle their life, why don't they spend 25,000 rupees on that? So there is we are starting our first center in Chennai. So I will connect Dr. Manju with them, or maybe we are in July, August, September, we are going to do some projects of starting up the lab also, so we can connect with the hospital and then we can start one by one. We can see how it goes further. So the benefits of AI and machine learning, this is like improved diagnostic accuracy, personalized treatment plan, and prediction of the disease progression, data-driven clinical insights. One thing I would like to say, I would like to emphasize here, we have a policy called confidentiality is our priority. We don't share the reports online. It is person to person and hard copy. We give it to the person, we post it to them by hard copy, then, or we give it to them which email ID they like, not even the WhatsApp. We don't use the files by WhatsApp. We don't have communications. I personally would not like to save the contact numbers, only through an email ID, then we know where it is going, or a postal ID. So this is the biggest thing I keep in all my collaborations. Confidentiality is our priority, and this is not a business, not connecting to a pharmaceutical industry to sell their drugs or something like that. This is purely person to person. It's personalized. Here, there are no sales of any pharma company drugs. There are no sales of nutraceuticals, nothing. There is an AI. I have about 1,000 recipes, and this AI connects to those recipes. So these recipes are there. And in Germany, I'm bringing out a recipe booklet in German and in English, but these are connecting out. So this is how it is. And this is how I want to go forward to. The clinical implications towards precision. Early intervention through precise diagnostics. If we know the intolerances, if we know the liquid biopsy, then we can make a tailor-made treatment regimes. I would request all the women and men both need, if all of you can get this liquid biopsy and intolerance test done once in your lifetime, then you will have a book, you will have a format like this, where you can choose, where you can have the information of the milestones. So that's how it is. This is the innovation milestones. Present, we have a lot of ultrasound, and I think present we are working on the microscopy and AI powered analytics. Further, I want quality of life. I don't want that a girl is going and getting, oh, I already have PCOD, I already have PCOS, I already have a tumor, I already have a myoma. 2007, I was first diagnosed with ovarian carcinoma. There was a myoma. They had to operate. I went in for a clinical trial. It's 17 years, and now I proved that I have a rare gene, and it only mutates because of my psychological status. Yesterday, I told Dr. Manju, I'm recording it today on 16th of April for my talk tomorrow. And I told Dr. Manju yesterday, I need to orient. It takes me some time to orient, and it's cold here, and I need to orient here. So early morning, I'm recording this before I go out for a walk. I leave my phone, everything. I think so. The quality of life matters. You know what Rajesh Khanna used to say, Babu Moshai, Zindagi lambi nahi honi chahiye, Zindagi badhiya honi chahiye. Means the life we live, we have only one life to live. So the life we live should be exclusively for us. If we don't secure ourselves, how can we do it? So this is where I would love to collaborate with PCOD, and that was one of the reasons where I'd like to join this conference. And these are the key preferences and the future directions and innovation, disease expansion, multi-omics integration, and point of care innovation, where we can create a point of care not only for PCOD, for everybody, for quality of life. The future outlook is for quality of life. It's just the future outlook, like I want the future outlook and imagine the whole shift for a person. That's why in Srinivasa Medical University, I had how do we take care of it? So these are the photos how we had a scientific writing workshop. Here, I bridged the gap between the faculty and students. I did the oldest method of randomization, that is numerical in-person standing randomization. I asked them to stand in the height order, and then they did not know, it was a surprise. And so I have enough of tools because I hold a Ford Foundation fellowship. I have enough of tools to separate in the groups, and then they came out with their titles, they wrote down the titles, for 3 hours they did not touch the mobile, and no AI was used. So this was a scientific writing workshop. And the second workshop I did for doctors to understand their position in the quality of life. All of them need liquid biopsy. Every person has an acquired and an inherited intolerance. Every person has an acquired and an inherited intolerance. Okay, so all of them need, and it's only one time investment of 25,000 rupees. I'm just surprised. It's a one time. It's just, even if you want to buy a ring today of 2 grams, it costs you around 35,000 rupees. This is a one time investment to know what you can eat, what you cannot eat, how you eat. There are separate recipes which you can monitor, which you can give time to. And that's how it is. Like this is how it goes on. And so we're bringing up together and putting all together, mixing up together and publishing together. This is how it is. So hopefully, I cross my fingers that everybody will be able to understand my message. So this is a spiderweb exercise. I did the activity, no presentations, nobody had the phone in the hand, nobody had anything. So they were all, for 2.5 to 3 hours, they were without any phone, and they enjoyed it, and happily they were like just happily there. So I also asked them to prepare the charts, prepare the meal plans among themselves. And this is how we did it in Srinivasa Medical University. All of them are doctors, and they really enjoyed it. And this is another similar kind of a workshop where we did the spiderweb workshop there. These are the faculty and the doctors of Bangalore Medical College. And this is where I'm looking forward to how do we combine together. So this is one of the summary and the outlook, like what we can do, key takeaways from the liquid biopsy, bridging the innovation. We do it in the lab. Okay, somebody sees, okay, there is one gene therapy survivor, there is Instagram going, but it's me. I'm not like, I don't want to come in person because I don't want to give a false hope for the people. I survived. I had the cells, like CAR T cells from my son injected here in my jugular vein. That was a gene therapy. But along with that, this was the major thing. No exercises, no gym to reduce weight. It was only the food. So I exactly know what the same thing I eat for the whole week. I cook on a Saturday. The whole week I eat. We in India have so much to get. We just don't make on Saturday. We just don't make our salads and put it in the boxes. And we say Monday, Tuesday, Wednesday, we can have a main salads. cucumber, but we need to know what exactly we need. That's personalized medicine. We need to know exactly. And global collaboration is where we have multi stakeholders, where we are sharing the technologies, where we can bring in, like freeze dried. We get coriander so easily in India. You don't need to do a freeze dry. I do a freeze dry. I put it in the freezer and it gets freeze dry, and I take some sticks out and then I cook it. I take a freeze dry. So, but in India, you don't have to do the freeze dry, correct? So, personalized medicine is not just, okay, we have this, it's a combination. No, we need to know what are our intolerances, what is reactive, highly reactive, low reactive, medium reactive. So then that's how it is. And I would like to collaborate from our Rurig Institute. We have many collaborations coming up. And this one, I would really love to collaborate with the participants here. And in July, I would love to be in the I would love to be along with the medical college to understand the students. We can have the workshops. Dr. Sujata Rathod is a director of medical education, and she has been, now I'm sending her a proposal to do it for the 22 medical colleges for entire Karnataka. I do it next week because I just want to see how I'm there, and the dates are discussed. What is the thing? What is the budget? Like she can say, it will be in the first morning. We do this spider web exercises, other exercises for them to free up, and then the groups are created, the students and the faculty together. And in the afternoon, like we have from 11, 12, 1. So we start at 10, 11, 12, 1, 3 hours. We have it in the quality of life in the morning. Then 1 to 2, we take a break. Okay, we take a break. And I would also like in the break, like I will give you a list, like we prepare our own salads, then we prepare our own thing. So we can have a kind of a break, 1 hour, where I teach them how to make the simple salads, how to have it, how to use the vinegar. So we can all have lunch salad. And 2, 3, 4, 5, 3 hours we need for the scientific writing, where the groups combine, come out with the topics, and I help them to write their scientific research papers and publication of the books. Because there is a book lying in their CV, it helps them the lifelong. I will teach them how the book is done, how we upload it, because Ramanujam Trust in India is giving for free ISBN number, but we need to know that there are reviewers to it. So this publication can be from each of your institutes, your students. So if you have a group of 25, there will be at least 40 publications. And this gives a credit for your institute. How 40 publications, each person is putting up their own case of quality of life. So you have 25. Then you mix the case studies and their case studies. Then you have another 25 papers. Mixing and matching, making a meta-analysis, making a review, making all together, then bringing the books. Each person can have a book, each person, because it's a person. So I have to give them the class how to go on with the summary of the book. We need to update the summary of the book, and we need to do this. So I'm looking forward in the collaboration like this. So we don't have to leave. So the summary of the whole session, I'm just giving the summary. So non-invasive real-time monitoring of tumor dynamics, whether it is a polycystic ovarian tumor or a myoma or any kind it is, enhance patient control and improved clinical outcomes, supports precision medicine aligned with palliative care goals. So we have a precision medicine, and you can bring in with the cancer patients for the palliative care. It is open to all. Everybody needs to have at least one time this one. So I know in India, until and unless a doctor records it, says you have to get it done, they will not get it done. So obviously it's like that. So this is what Dr. Christopher and we all, that's a summary from him. So this is where we eliminating the need of painful surgical procedures. This is what I want to bring in with a liquid biopsy. There is a breast cancer, you need to have a biopsy. They are just afraid till you get a biopsy, till you get a mammogram. They're just shivering till they come. And this brings down psychologically so much. There is no production of serotonin hormone, and automatically the body goes on a rejection and an inflammatory process. So I have tried my best not to bore you with the last 37 minutes and a video recorded. I hope as my video recording is going on, I hope that I am there together. And this is the scan code. to fill up the feedback form of my thing, and that's where we have the website, and I have my email ID, and I would love to welcome the collaborations, and I'm very, very happy that if I can collaborate with all of you. I hope, like, I'm trying to make this presentation understandable, because it's too difficult for me to be online. I would love to be in person, and you can see me now nicely, like how I was. Imagine 156, my hair is all falling up. Now you see I have good amount of hair. I'm 48 years, it's standing, like, all the electrons and everything. I'm not stressed like that. It doesn't happen, transition doesn't happen like that. It's not a miracle. You just have to make it out. So this is a scan code. I have left the scan code, and if you fill the feedback form, so we have some books, and we can collaborate, answer your questions. So I would really, really request, as you're watching this video, I'm standing here, I'm like staying here on a video call and talking to you. Please, please, please scan the code. And so that I would love to communicate with the participants. And I would love to know that if you scan the code, it means that you heard my presentation. Otherwise, I feel so painful. Like, it took me really, it's taken my 25 years to come to this conclusion of the presentation. And obviously, the last 8 years, the struggles I have had and coming to the presentation was not easy. So I just want you to understand, and I just want you to collaborate with us. And also, I'm living here. These are my two LinkedIn. This is my LinkedIn, and that's Kamran's LinkedIn. We also have Christopher's LinkedIn. I would like if you can join Abdul Majid Kamran's LinkedIn. Obviously, like a mother promoting the son, nepotism, you can say whatever it is, but he has been with me since he was 7 years, traveling around. So when you go to his LinkedIn, you can see his projects with his real original photographs. And he's now the CEO. He's 20 years, but he has been with me the last 11 years. With his mother, and he has traveled across, and he comes out with ideas. And he was the one, he said, we have so many blood samples with a microscope. We bring in a robotic microscope, and then we bring in a robotic microscope, and how we can leverage the time, and how we can give it out in a thing. So I still leave my scan code here, and it's 40 minutes, and I have been given 45 minutes. I hope, like 5 minutes, I want to take up the question and answers, and I'm just requesting, like, I hope I can be there online. And I would just like to thank all the organizers, and especially Dr. Manju being like communicative with the time zones. And I would love to meet you, and I would love to visit. Pondicherry is one of the things very close to my heart. Before, there was SLI, Sustainable Institute for Sustainable Livelihood in Aroville. So I was also on the Aroville radio on health education, and give workshops on women there in Aroville. And Samanvaya is a trust where now it is by Ramasubramaniam. I will connect Dr. Manju with Ramasubramaniam through Samanvaya Trust. And I'm there all the time. There are lovely photographs of me with Aroville, with the meditation center. And yes, my association with Aroville is almost 15 years, from 2010 to 2025. So Pondicherry is something like, I always love the beach to walk around. And of course, we were there in Pondicherry when there was demonetization. And we picked up, like, the last 1,000 rupees we have used is we picked up 2 t-shirts and 2 pants for Kamran, that's my son. During the demonetization, I had a bet with him that if I get the train ticket, he comes with me. So the first time he came with me to the grandmother, so he was always been helping me in the workshops, taking photos, communicating, and now he's helping me to put all my 1,000. There are around 10,000 recipes from last 25 years for each person on the clinical basis. Every person gets their own personalized. Now he has connected the AI. Now we are bringing up the robotic microscope. He's doing his bachelor's of engineering in robotics, and he will complete next month. And that's how it is. And this is my team. I have Dr. Christopher Rurik, that's my German husband. So, and we are going to get official marriage in the court in the next 2 months. We have to wait for 2 years. So now my son is 20, and I have a German palliative care, 42 years of experience. We are combining all our knowledge together. so that we can help give back something to the world as a community. We can do it as a business module, but that doesn't give me the happiness here I have, so that's how I want to connect. And this video is 42 minutes, and nearly by the time I say thank you and bye bye and get back to you, it should be 43 minutes, and I completed my time in 45 minutes. Thank you so much, and thank you for listening to my video recorded, not in person. I would love to be in person because I want to see the smiles of everybody. Thank you so much. Thank you. I think I'm lucky to be here as the presentation was going on because our morning meeting got cancelled for the next week. Welcome to German bureaucracy. So I'm here
Thank you.
live, and I can take questions. Professor
Sujeta,
Sucheta
ma'am.
is on the,
Ma'am, it was a wonderful talk, ma'am. Sujeta, ma'am.
Yes, madam. Thank you.
Yeah, she is my like Professor
Yes,
Sucheta is my anytime on call.
I'm first of all thank madam a wonderful presentation and insight about liquid biopsy and its application for diagnosis and especially intolerance diagnosis. It's a very eye-opening session. Madam, thank you very much, and a lot of matters you covered within a short time. I think we need a lot of time to analyze. Even we have liquid biopsy setup, but in NIPTE we had, but very minimum use. I don't think they are used maximum. But it gives a lot of knowledge. I think it's a very good. And on behalf of our conference uh, chairperson and all the organizers, I thank you very much, madam, for your real effort to come to present this your knowledge. And I'll thank Manju madam given me an opportunity to chair the session, and all the organizers. I'm very grateful to you on behalf of on my own and my university. I thank you very much.
Thank you, ma'am. Ma'am, over to Dr. Sarkar, sir.
I have a few questions, if you permit, if the administrators permit me. I'll go through them as fast as possible, and you may answer them as briefly as the time allows you. Number one, as I understand, there's no place in India where we have liquid biopsy. Am I right? Specifically.
There are places in India for liquid biopsy, but the interpretation depends. So the
Okay.
liquid biopsy centers in India mostly are controlled by the pharma industry, where they do the liquid biopsy to prove that they need this chemo drug or this one. It's something like a scissor. You have a scissor. We can use the scissor to cut the cloth, cut the paper, cut anything, or make a beautiful craft work, or just cut the plants. So the liquid biopsy systems are there in India, but nobody is putting this liquid biopsy to put an interpretation for food as medicine. Especially the circulating DNA, tumor cells, everything they will do. They will just make it. The cost is very high. The cost is 2.5 lakhs to 8 lakhs for a liquid biopsy in India.
Oh, okay.
And they send the samples from India to Singapore, send the samples from India to US, but not to Germany because of the rules and regulations. And it adds on the cost. It goes up to 25 lakhs, but it can just be 25,000 rupees.
I know one of Robin Cook's novels deals with liquid biopsy.
Yes.
How to send samples to you? That is one question. I know, I mean, need not answer it now because it would consume a lot of time.
Very simple. I spent about 5 years clearing all the regulations, and I spent around 35,000 euros getting all the regulations done. The samples have to reach to Bangalore. From Bangalore airport to Frankfurt airport, I have cleared that. So there is no worry. The samples can be sent to the Bangalore.
As of now, if I need to send a sample, I need to send it to Bangalore, and from then onwards, they will take care of it.
Yes. See, it's very simple. I am I'm not working on a business module here. It's a box of 2 kilos, and it's a space. In this box of 2 kilos, you can send 100 samples at one time. It is same 250 euros for this box.
I get it.
And
Yeah.
if you send one sample in this box, also 250. This is where I'm not making money. I can make a lot of money with this, with transportation. But I'm not doing this because I want it to go. In this way, it is coming to 25,000. So the whole total cost, including the transportation, is coming for 25,000 with 287 intolerances.
Get it.
But
I
when
get
we
your
go
point.
for liquid biopsy, also it is the same. So what will happen for 50,000 Indian rupees? You get a liquid biopsy and an intolerances IgG antibodies. It's two together. But somebody is
Okay.
worried, I don't want to get the liquid biopsy for a marker because I don't want to know if I'm going to get cancer or not. We don't need. Just check a intolerance test. So this one I have cleared. It took me 5 years.
Can these samples not be stored in Bangalore for quite some time, in maybe -80 or so, till the box fills up, and then you send it over?
Oh no, we don't need to store at all, because when whether it is EDT, blood, whatever it is, we are pulling out and we are taking the serum out of it. Even if it clots, we have the serum.
Okay.
So it doesn't need to be stored at all. We don't need a storage. It can just be kept in the fridge, because see, these are the games the business people play. Because they say, no, we have to store, then they will charge more on that. And I don't want that this thing to be laid on the patient, laid on the person. When you add all this storage, when you add the transportation, instead of 25,000, it becomes 50,000, 1 lakh, 2.5 lakh.
I have one
So
last question. Yeah, please
Yeah.
carry on.
Yes, please. So we can store it in any room temperature, and you can store it in any room temperature.
Okay. And last question. I have a 8-year-old girl who is severe, some sort of an unknown atopy she has. I would like to send a sample. So
Sure.
So that can be done. I can send it over to Bangalore, and
I
that can
can
be
send
done.
it
Okay.
over to Bangalore. So
Okay,
see, if you have seen that, then we can do both. See, if we do one time the sample is coming, we can do the liquid biopsy and the intolerances. 200, every person has intolerance acquired. What they do is, I have seen the doctors on the high, every table when I go in India, there are 5 drugs sitting on the table. At least one will be there on every table. That is pantoprazole, omeprazole, Rantac will be sitting there. This will be sitting there. Forget about paracetamol, limulicide, diclofenac. Forget about that. Every table when I see there. And these 3 drugs are literally the biomarkers for dementia and Alzheimer. Right? So we know this. And if we can stop this, we can say we don't have to take a Rantac. Okay, no, I have some gastric irritation. Take a Rantac, Pantodoc, omeprazole, pantoprazole. There are hundreds of varieties of that. They don't stop what is bringing them the bloating. They don't stop what is irritating them, like rashes, under eye dark circles, puffiness. And the women after 30 and 35, now 30, premenopause, the mood swings, they get irritated fighting. See, imagine if the parents are fighting, a parent of 35 years will have a child of 10 years. Mood swings are going on. You can see so many jokes on Instagrams, reels going on between husband and wife and parents. What is the effect happening to this child? And you don't decide, okay, you decide engineering or medical or whatever it is, but you don't know what the real child is. Even children have dementia. It's not dementia. Children also forget. See, what can they do when the stomach is paining? They can't. That's what is my role now. Like, I'm not saying about the girls. What about the boys getting an acne? Yeah, they're not saying anything. So this is where I want to go forward, and I'm thankful to Professor Sucheta. In July, when I'm there, we will be in Srinivasa Medical University, because we have an MOU with them to design only for the intolerances for generic drugs, 10 generic drugs. I have already, Professor Sucheta told Dr. Shabaraya and Mithun, I'll prepare a proposal where metformin, they just forget about amlodipine and metformin. Oh, my blood pressure is up. Everybody has a device at home. My blood pressure is up. Oh, I take this one, you take this one. They just check a drop of blood at home. My blood sugar is up. Oh, I'm already taking this medicine. Please take this. But how do you know? It's not a chocolate. Even tomatoes, one variety we eat, forget onions. We have different types of onions in India. We don't use the sambar onion for biryani, right? Or palau. So how is it different? So this is my takeaway. Thank you so much for this.
Dr. Avmc, I'm so sorry. We're running out of time, so we need to conclude.
Sure.
And I'm being signaled by people around me that it's time we start. So thank you so very much. And as a token of appreciation, we have a certificate. And that's for Dr. Afu. That's for you. Thank you so very much. It was really wonderful. I mean, scientifically as well as I really loved it. So thank you so much. And also a token of appreciation for Dr. Sucheta. It was wonderful, ma'am. Listening to your introduction.
Thank you.
Thank you again. Dr. Afu will be in touch. Thank you.
Yeah, sure.
Thank you, ma'am. Thank you, Professor Dr. Afu.
Thank you, sir.
Sujeta, ma'am.
Thank
you so much.
Thank you.
Thank you to our esteemed speaker, chairperson, and to Dr. Gautam Sarkar sir and Manju ma'am for that excellent session. We now move to the final session of the morning on the topic impact of microglia in neurodevelopmental disorders. I may now request our moderator, Mrs. Hemalata ma'am, Assistant Professor, Department of Physiology, Avmc, to kindly take over the session. Over to you, ma'am.
Good morning, everyone. Now we are moving to the last session of the scientific session from the Dr. Sovan Bachi. The topic is impact of microglia in neurodevelopmental disorders. To chair this session, we have our Dr. Damodar Gowda sir. I would like to introduce the chairperson of the day. Dr. Damodar Gowda sir, presently working as a professor in the Department of Physiology in Siddhaganga Medical College and Research Institute, Tumkur. Sir has done is MSc from the Manipal Medical College, Mangalore, and PhD from the Nitta University. Next slide. Sir has research interest is molecular biology of the aging and fetal programming. Sir has more than 60 publications and the 600 citations. So sir is having the number of the STS projects and the DST project funding projects. He has received multiple best paper awards and he has presented his BMS Con 2022 and his paper has received the best oral presentation. Welcome you, sir. Now I request Chairperson sir to introduce the speaker.
Thank you, Dr. Hemlata. And at the outset, I would like to thank the organizers for inviting me as a chairperson. So it's my privilege to introduce our distinguished speaker, Dr. Sovan Bagchi. Am I audible?
Yes, sir. Yes, sir.
Okay. So it's my privilege to introduce our distinguished speaker, Dr. Sovan Bagchi, Director of BBMS Program and Professor of Physiology at Gulf Medical University, Ajman, with over 27 years of extensive teaching and research experience across India, Ethiopia, Libya, and the UAE. Dr. Bagchi is a highly accomplished academician. He started his profession as a lecturer in physiology at Acharya Sri Chandar College of Medical Sciences, University of Jammu. He continued his service there as assistant professor till 2004. Later, he moved to the College of Health Sciences, Ethiopia, in the year 2004. Then, in the year 2007, he moved to Libya as an assistant professor in physiology, followed by professor and head Department of Biomedical Sciences Dehradun, India, where he worked till 2016. Then he became the director, BBMS program, and professor of physiology, College of Medicine, Gulf Medical University, Ajman. So his expertise spans neurophysiology, cardiopulmonary physiology, exercise science, and biomedical research. He has been recognized with prestigious fellowships and awards and has an impressive record of publication in international peer-reviewed journals. So today, Dr. Bagchi is going to enlighten us on the topic impact of microglia on neurodevelopmental disorders. So over to you, sir.
Oh, thank you very much, sir.
Welcome, sir.
Thank you. And still, it is morning here. In India, it is afternoon. So, good morning and good afternoon. Can I share my slides now?
Thank you, sir.
Yes, sir.
Okay. At the beginning, I wish to thank the chair of the sessions and the university for arranging such a beautiful. I was with you for last half an hour, and it was really, I enjoyed the session. For some reason, there is an urgent meeting at my university and that will start after 20-25 minutes, and I have to attend that meeting. I'm sorry, I will complete my presentations before that, and I will not be able to take any questions, but I'll be love to have them in my email, and I will definitely answer them in a short period of time. Thank you very much. And this is the impact of microglia and neurodevelopmental disorders. Roughly around 100 years back, the French group of scientists, they have seen this, a peculiar kind of cells in the nervous system, and they were not very sure about the functions of this microglia. But there was a good amount of research till 1940, and after that, for some reasons and some kind of requirements of the world scientific community, this microglial research was somehow in a halt. 1990 onwards, this microglial research has taken a tremendous speed, and now at 2026, we have come across a long way, and microglia is the center of neuroscience research. With this note, I'll begin my lecture. I always say, we'll start with a lighter note. Before the brain can think, that means before the development of the brain started thinking, started analyzing, the microglia, they decide that what to be stayed in the brain and what goes. And the functions of the microglia is to maintain a healthy neurons stay and unhealthy to go. This was the concept. This was the the theory till 1980, 1990s. And they used to say, oh, the microglia is nothing. It is just to cut the things which is extra, like the gardening scissor. But later on, it was found it's a remarkable, the group of cells. They do many things other than this. And obviously, this is one of their functions. So we'll concentrate in next 15 to 20 minutes on the neurodevelopmental disorders and the role of microglia. We have several kind of spectrum of neurodevelopmental disorders, ASD, autism spectrum, ADHD, schizophrenia, all those things. And when there is a neurodevelopmental disorders, there is a problem. The problem is it's a cognitive and behavioral issue. They need a lifelong support. And for that, there is an economic burden. And there was a few group of scientists who work on the health economics. They found out it is in a billion, Western countries, they spend on just to maintain this neurodevelopmental disorder patients. So it's a huge money. It's a huge money. It's a social impact is also enormous. All those things, that means to overcome this, there is a need to understand the neurodevelopmental disorders and small bit what a microglia does on it. The neurodevelopmental disorder, why it happens? It happens due to abnormal proliferations, impaired migrations, maybe synapse formation is a trouble, or they make synapse but faulty. And these are the major reasons behind the neurodevelopmental disorders. And here comes the role of microglia to make it in a proper shape, as your garden is. To do these things, we have concentrated mainly on the autism spectrum disorders as a model of neurodevelopmental disorder. There are plenty of neurodevelopmental disorders, but the most important is the autism spectrum disorder. The reason why it is most prevalent among all, and it is widely studied, the microglia and immune reactions, and the clinical phenotypes are mainly in the ASD is the social communication deficit, restricted behavior, and all those things. Now, I will not go much detail of the autism spectrum disorders because my intention to speak about what the microglia can do to give you a healthy life, better life in neurodevelopmental disorder patients. So we'll go back to quickly we'll go to the ASD and we'll go to the microglia. Now the strong genetic basis, it is 1920 we have found, there is ASD, there is a genetic basis. But the problem with this, that when we try to explain the ASD etiology, the genetics is not enough to explain all those things. And since it is not enough to explain, we cannot have any effective therapeutic, the effective therapies to deal with this ASD. But we have found that ASD, the autism spectrum disorders, they have a close relations with the immune dysregulations and microbiome alterations. And some of my colleagues observed that human patients and rodent, we have done on some of the experiments on the human patients and some of the rodent models, we have found that immune dysregulation is the factor. And there is a relations between immune dysregulations and microbiome alterations. So there is a link. So if we can address these two, so hope that we can have a better answer tomorrow. There is some other, I'll just skip those things. Another immune, the neurodevelopmental disorders, that's one of the most, a rare disease, but the importance here, they're the monogenic, the Rett syndrome. I will go quickly, I'll skip this one, and I'll come to my hero here. That's a microglia. But it does actually. it does what not? It helps in the myelinations. It helps in the synaptic remodeling. It helps in repairing of the injury. It also important in phagocytosis and maintain the, reduce the inflammations, whatnot. It does everything at different levels. Different levels at the means at the level of ultrastructures, protein expressions, omics profile, or the morphological structures at the end. So it is one of the finest, one of the most interesting neuronal cells, the microglia is. Earlier, they used to think this microglia, they derive from the myeloid precursor and they mature in the CNS. But here there's a very, very interesting point. Though they mature in the central nervous system, they maintain a particular transcriptional signature. And this, more than the therapeutic things, as a scientist, as a researcher, this is the one of the finest catch that was published in 2013 and 14. This distinct transcriptional signature reform. And for that, we had identified them as a between, we can differentiate between the peripheral myeloid cells and the cell which is engrafted in the CNS. Now, the autism spectrum brain, they show increased microglial density. It means, usually, what are the concept, general concept about the microglia is, microglia cuts and keep the things in shape. It's a Caesar. But here ASD, we found increased microglial density. That means they are more active there. Can be one of the, one of the theory behind it. But as we progress, we will understand it is not only the cutting and putting the things in shape. This is also the show the microglial activations and progressive loss also in case of the ASD syndrome. Now, microglia, they change the synapse numbers during development or injury. What they do is this. What they do is here, they reduces sometimes, not always it is true, and different levels it does. So what they do is they mix this prenum here at this level. Here. And they have eliminations, they have increased the plasticity. And we have seen whenever you stimulate these microglial cells, in vivo, with some of the stimulant that creates the inflammation side, the LPS, and microglial activity increases. That means microglia is not only for the cutting and keeping the number of neurons in place or number of neurons limited. They're also important for interactive and crosstalk with the immunological system. Okay, now they are also as the, this is the common belief that microglia, they reduces number of neurons. So yes, of course that is. And the excess of the microglia, they are removed by programmed cell death. And here a very interesting part, and a few of my colleagues here, they described first that we used to see that NGF, neuronal growth factors, usually they are for the growth of the neurons. But in this case, microglia somehow manages to have found the microglial relationship with the neural programmed cell death through neuronal growth factor. This is a very, very interesting finding in the past few years. Microglia, they also induce the apoptosis in different cell like spinal cord, Purkinje fibers, and different mechanism they follow. They do the motor neuron loss that's mediated by TNF alpha, superoxide ions in the Purkinje cell death. That's all. They do their functions by reducing the number of neurons in place. So the chances of the cross connections, chances of the altered synaptogenesis will be less. So yes, of course, that is the function of the microglia. But microglia also have a very important function, exactly the opposite what we think of. The microglia, they promote the neuronal survival rather than only initiating the programmed cell death. They do it by some of the CX3-CRI proteins, and they mediated IGF-1, the insulin-like growth factor release, and they supports the neuronal viability. That means microglia, in one hand, it is reducing the numbers of neurons. The other way, it is also helping to maintain the neurons. So that means microglia is doing the both. Now the question is how to trigger, how to signal the microglia to go for the survival or go for the stimulations of the programmed cell death. That is the real questions comes in the mind recently of the all over the world, the microglial scientists. Microglial, they, as I told you earlier, they also removal of already dead neurons. Yes, of course, they are fine. There is phagocytosis. There is a number of thinning of the myelin sheath. They on the astrocytes and all those functions. So that is fine. That's one of the functions of the microglia. But very interesting point is microglia, how they eliminations and synapses. These are the how this signaling the microglia understand when to initiate the survival and when to initiate the eliminations. That is the major questions. This question is answered few years back by series of experiments. And this series of experiments are on the hippocampal cell, on the auditory brain stems, and the hippocampus. And they say, roughly they say, eat me or don't eat me. So that means the neurons, the microglia will express certain things in the neurons. They initiate the eat me signals or non-eat me signals. How do they do? They do by a mechanisms, we call them the phosphatidyl serine mechanisms and don't eat me signals, that is by CD47. And now we can understand in a better way how they manage the survival. At the same time, they manage the increase the neuronal cell death. Microglia, as I was telling before, the microglia, the common understanding among the neuroscientists, among the physiologists, that the microglia is for eliminating. But it is not only eliminating, it is also the synapse formation, proper synapse formations. And series of articles, they proved it, thus microglial depletions, you'll find the impairs in the motor learnings, microglial contact stabilizers dendritic spines, as I showed you before, and adult neurogenic, the dependent the spine formation. That means it is not only the clearing the things, it's also remodeling the things. It is also making the synapse form newly. How do they do? First, they identify which one to come, which one to stay, which one to go. As I started my lecture by saying this, which one to go, which one to stay. This is decided before your brain started functioning and analyzing, started understanding. I'm sorry. Now, they do it by two mechanisms, as I told you earlier. And now the further, by the release of BDNF, the brain-derived neurotrophic factors. We have found that if you do it and co-culture the microglia with the IL-10, you will find this spine formations, and it was very, very important piece of work done by Lim et al. In 2013. And in the last year, 2025, September, I met this Lim. Wonderful gentleman, wonderful scientist, and really he is giving insight into the microglial functions and saying that we can use this microglial, modulations of microglial, give the answer tomorrow on all the neurodevelopmental disorders. Now, some of the evidence we worked together, and we found that ASD model, when we developed the autism spectrum models in the mice, and this mice is a special kind of mice where the maternal immune system is activated. We call that MIA, by injecting usually LPS injections we do, and increase the dendritic spine here. And that means it gives you a lot of spine density. And when they give the spine density, chances of cross connection, chances of wrong synapse formations are more. And when it happens, this is where the role of microglia comes. If you have a less microglia here and they're disorders, they're not functioning properly, you will have a kind of a issue here. Now, as a whole, this slide is the slide where we took all the functions of microglia together. They are important for neural cell death, helps you in reducing the number of neurons. Also, neuronal survivals, it helps in the IGF through the IGF and neuronal growth factors. It also synapse remodeling by CD47 mechanisms and spine formations, and it happens in the synapse remodeling in many of the conditions, or cell and ECM clearance. Now, a group of scientists in India, whom we are collaborating nowadays, and they are coming up with a very interesting findings. They are saying, can you talk? They told us that, can you speak in a language the way we speak? It means to say that, is there any relations of this nutrition's microbiome, the gut microbiome, the microbiologist, and we, the physiologist? Is there any relations? And we found some relations, and they are really, really very interesting area to work on. Microbial and the neurodevelopmental disorders. We found some of the articles here. Some of them we also collaborated. The gastrointestinal disease and altered microbiome, that's very, very common in NDD. So that means microbiome, the mechanistically shapes, microbiome, they shapes the microglial functions and influencing the brain development and the functioning of the brain at the developmental stage. And we have also found during the ASD, as I was telling, we are taking the ASD as a model to understand the microglia. So we found in the ASD patient, both in the mice and also mice model, also in the human, the clinical studies with the patients, we found both of them, the ASD, we found reduced number of bacteroidetes, and here we got a very good collaborations with some of our colleagues, and increased amount of Clostridium lactobacillus they found both, and these alterations are found in the ASD. What happens if we do certain experiments? Few experiments we planned and we did it. What are the experiments? Experiments are we did by a activated immune model of the mice, and we added some of the bacteroides fragilis, and we found this mice improves the communications, repetitive behavior is reduced, that means indicating towards a potential treatments of the ASD, and the common symptom is the repetitive behavior there in the ASD. We have done another one. Another one is we did it with the maternal high-fat diet model, the mice, with the lactobacillus, and we found this limits the behavioral abnormalities. Okay, we did another thing. That is, we made a germ-free mice and microbiota of ASD. We implanted there and induces, and we found the repetitive behaviors, communication deficits, and all those things. So these are indicating towards a potentials, therapeutic potentials on the neurodevelopmental disorder entity. I will skip this one. This is a detail of this thing, and I'll come to this area where the microbe-derived metabolites influence the microbial functions, like gut microbiome. How they do? They do it by some of the metabolites like cresol, the short-chain fatty acids, and they ultimately activates the microglia. And then we found the altered neurodevelopmental or the ACE. Now, if you go one by one, like short-chain fatty acids, they're gut-derived and potential link to the neurodevelopmental disorders through microglial pathway. We have also found the cresol. We found the elevated in the urine in the children with the autism spectrum disorder. So they are the indicators. They are doing something on microglial activations, and CD68 mainly they are targeting, and they includes the all of them, the cresol, the short-chain fatty acids on this. We did one more thing. What happens to the true physiology, where we started talking to each other on the microbiology and the physiology together? I will keep the gut microbiome with this, all those, and at the same time, we'll have a vagus nerve stimulations. What happens here? We have the behavioral output impact is really, really good, and it reduces the pro-inflammatory signals. Pro-inflammatory signals means that is having a potential therapeutic potentials towards the neurodevelopmental disorders. And here, with the physiologist and with the neurophysiologist, we started collaborating with the microbiologist, and we found there is a very, very important role here between this neurophysiological aspects and the microbiota. And this is where this whole thing comes together. How the microbiome regulations, immunological crosstalk, and ultimately that leads to our reducing the pro-inflammatory. Now, what is our future directions? Future directions: talk, and talk, collaborate, and collaborate. It is with the microglial people, it is with the microbiologist, it is a microbiome with the neurodevelopmental disorders, the clinical people. All together, we found the answer of this neurodevelopmental disorder, especially when you talk about the autism spectrum disorders. What kind of a crosstalk? The microbiome, immune system, and vagus nerve, they interact reciprocally to modulate the microbial biology. And short-chain fatty acids modulate T-cell response. Inflammation reshape the gut microbiome, and the vagus nerve, they also reduces this. So future goal is a tridirectional interplay of the important microglial functions in NDD, the microbiome, the immunological aspects, and the vagus nerve, three together, and we can find some of the answer in future. So future goal would be, I'm very, very sorry, I have to go for this meeting, and very important meeting on the university level, and I had to leave, and I will conclude very hurriedly. I'm sorry for that. And future goal is to investigate how environmental exposures they alter the microbiome. So another one has come. And nowadays, when I was talking to some people and few months back, they are saying there is a change in the microbiome due to the climate change, and climate change has an effect to this microglial functions. And one group of people are working on this. I have very, very less idea about it, but they're claiming that this also has a role here. So altogether, we can find answers and we can translate into the pathways that identify the novel therapeutic targets that can microbiome modulations can be the anti-inflammatory strategy, diet-based therapies, and altogether we can find an answer. And with this, I thank you for your patience hearing, and I will love to answer all your questions. I'll put my email ID on the chat, and I think that will be a good thing to do, and hope that that will be nice. I'll put my email ID here. You can communicate with me in the chat box I'm writing here. I'd love to have any answers for this.
Thank you, sir. It's a wonderful session. Over to the chairperson, sir. Sir, kindly unmute, sir.
Thank you, Dr. Bakshi. It's actually a very insightful talk, and it's an eye-opener because the microglia, it has got it acts like a double-edged sword. It can activate the neurodevelopment. Also, it can cause neurodevelopment disorders. And actually, I was much interested in asking something from you, like for example, the gut microbiota, how the gut microbiota activates the microglia, and at what stage of development the microglia has more impact on the neurodevelopmental disorders. As I mentioned, I think I will be sending the questions via email. I hope we get a good answer from your side. And once again, very thank to your insightful talk. Thank you, sir.
Thank you very much, sir. And I love to answer your questions. I love to collaborate with you. And I hope that we will have a fruitful collaborations in future. Thank you very much, sir.
Sure.
Thank you, sir. We are at the end of the session. On behalf of organizing team, we would like to felicitate with a e-certificate and the memento. Thank you, sir.
Thank you.
Now I would like I also like to thank our chairperson with a e-certificate and memento. Thank you, sir.
Thank you so much.
Yeah, on behalf of BMSC team, I thank our speaker, Dr. Bhakti sir, and Dr. Damodar Gowda sir also for spending their valuable time in our academic forum.
Thank you, sir. Thank you, Dr. Gopinath.
Thank you. Thank you very much. Can I leave now? If
Thank you, sir. Thank you. Thank you very much, sir.
Thank you. Thank you very much.
Thank you to our respected speaker, chairperson, and moderator, ma'am, for that wonderful session. With this, we come to the end of the scientific session of day 2 of BMS Econ 2026. I extend my sincere thanks to all the moderators, speakers, chairpersons, and participants for their valuable contributions and for keeping the sessions engaging and on time. We will now break for lunch and will further proceed to the scientific presentations. And great sessions are guided by great moderation, and today has reflected that. Thank you.
The delegates can join for the scientific presentations, which is happening in the afternoon also, in the same link. Thank you.
We are closing this meeting now.
We closing or we are putting some video and running through?
We can play some video also if required. Shall we play video?
Oh, for 1 hour. Because this
Okay,
link
we are playing. Yeah, we are playing 2 videos now.
maybe for some 15 minutes and then we can close. Okay.
Yeah, then we will close it.
Okay.
And open the separate meeting, right?
Separate meeting
For
for
2
us.
o'clock.
Yeah. Yes. Sir.
Okay, sir. We will play 2.
The future will be owned by those who are powered by knowledge and wisdom that transcends time. There is one place where such wisdom is imparted, building individuals to build the world. Welcome to
Vinayaka Mission's Research Foundation, deemed university.
The university, with 27 constituent colleges, delivers cutting-edge knowledge across various disciplines. Medicine, engineering, architecture, management, health sciences, dentistry, measuring up to 135 courses of study, all covered across sprawling and student-friendly campuses. At Vinayaka Missions University, students of various disciplines hone their knowledge right up to doctoral levels. At any given point, there are 15,000 students studying in the campuses. With the vision of creating medical professionals who can meet the needs of the Indian and international communities, Vinayaka Missions University has made a significant contribution to the field of medicine. Four colleges and hospitals in Salem, Karaikal and Puducherry not only groom students into medical professionals, but also ensure easy and affordable medical help to the local population. Beyond medicine, the university is a multicultural hub that has students gaining expertise in a wide range of fields. Our engineering courses are designed to give students comprehensive knowledge in all contemporary fields of study. This is strengthened by state-of-the-art infrastructure. Engineering and technology apart, Vinayaka Missions University is known for its courses in dentistry, pharmacy, homeopathy, nursing, allied health sciences, physiotherapy, architecture, arts and science, and management. Our libraries are well appointed and are a digital and physical resource for both students and faculty. Linked to the central online catalogue, students have access to over 145,000 books, 1,000 journals, and over 5,000 audiovisual aids. The hostel facilities at the campuses spell absolute comfort and provide the right ambience for self-study for the students. Our students are thoroughly encouraged in sports and cultural activities. Besides successfully participating in inter-university sports contests, our students have also excelled in cultural meets and festivals.
Bringing minds together in search of endless wisdom, VMU. Building individuals to build a world, building hopes and dreams unheard at VMU. Friends to stay, VMU. Enjoyment and learn and play, showing the way ahead each day. At
Vinayaka Missions Research Foundation, Salem.
The future will be owned by those who are powered by knowledge and wisdom that transcends time. There is one place where such wisdom is imparted, building individuals to build the world. Welcome to
Vinayaka Missions Research Foundation, deemed university.
The university, with 27 constituent colleges, delivers cutting-edge knowledge across various disciplines. Medicine, engineering, architecture, management, health sciences, dentistry, measuring up to 135 courses of study, all covered across sprawling and student-friendly campuses. At Vinayaka Missions University, students of various disciplines hone their knowledge right up to doctoral levels. At any given point, there are 15,000 students studying in the campuses. With the vision of creating medical professionals who can meet the needs of the Indian and international communities, Vinayaka Missions University has made a significant contribution to the field of medicine. Four colleges and hospitals in Salem, Karaikal and Puducherry not only groom students into medical professionals, but also ensure easy and affordable medical help to the local population. Beyond medicine, the university is a multicultural hub that has students gaining expertise in a wide range of fields. Our engineering courses are designed to give students comprehensive knowledge in all contemporary fields of study. This is strengthened by state-of-the-art infrastructure. Engineering and technology apart, Vinayaka Missions University is known for its courses in dentistry, pharmacy, homeopathy, nursing, allied health sciences, physiotherapy, architecture, arts and science, and management. Our libraries are well appointed and are a digital and physical resource for both students and faculty. Linked to the central online catalogue, students have access to over 145,000 books, 1,000 journals, and over 5,000 audiovisual aids. The hostel facilities at the campuses spell absolute comfort and provide the right ambience for self-study for the students. Our students are thoroughly encouraged in sports and cultural activities. Besides successfully participating in inter-university sports contests, our students have also excelled in cultural meets and festivals.
Bringing minds together in search of endless wisdom. VMU. Building individuals to build a world, building hopes and dreams unheard at VMU. Friends to stay, VMU. Enjoyment and learn and play, showing the way ahead each day.
Vinayaka Missions Research Foundation, Salem.
Vivek, please close this meeting now.
Okay, sir.